Yeah,
Shailesh, you have to go first.
yeah. Good evening, everyone. I welcome you all for this 8th edition of the Spine Weekend Pune, and this was a venture which we started in 2013. Primarily, this meeting was an offline meeting, and we used to do live surgeries and debates and discussions. But this year, we thought there are a lot of meetings already going on, and therefore take a break, have relaxing seat at home, and connect with each other once again. And we have a stellar faculty from all over the country. We have the president of Association of Spine Surgeons of India, Shankar Acharya sir, as an academic chair for this show today. We welcome you, Shankar sir. We have Dr. Parag Sancheti, the chairperson of Sancheti Institute, and a strong support for all of us for this meeting for so many years. And sir is recently elected as the president of Asia Pacific Knee Society. We congratulate you for the same, as well as we thank you for being here, Parag sir. And we have none other than Maharashtra Orthopaedic Association's president, Dr. Vasudev Gadegone sir, who is immensely supporting us for all the academic activities which are ongoing. We welcome Dr. Gadegone sir as well. At the same time, in the same breath, I would like to thank all the core members of our team, my colleague, Dr. Ajay Kothari, my colleague, Dr. Siddharth Aiyer, and my colleague, Dr. Pramod Bhilare for this, and Ashok Shyam, of course, who is giving us a lot of inputs for this meeting. I just would like to brief about this meeting that we will have some debates, some discussions, some non-academic talks, and some interesting case which a lot of stalwarts will be talking about. This is about this 3 hours spine weekend today, and tomorrow also we will have the similar glitterati of spine surgeons from all over India. I would like to thank all the faculty who have accepted the invitation for the weekend and giving their valuable time for us today. And I will introduce during their talks and debates. Thank you all, and I would request Shankar sir to proceed.
Good evening. Thank you, Shailesh, and good evening, everyone. On behalf of ASSI and this very nice webinar, which has been set up by Dr. Shailesh and Sancheti Hospital, I welcome you all to this excellent evening and today and tomorrow. I actually feel envious of Shailesh because he's got Dr. Parag's support and Ashok Shyam, who's really done a marvelous job of spreading education through OrthoTV. So he's got double advantage. So he's all over the world all the time. So I really feel envious. And these last 2 years, he's been doing webinars with the amount of enthusiasm and energy that I don't think any of us would have. So he's always full of energy and non-stop he keeps talking. So welcome. And I'm sure this session is very interesting because he's put up a very nice program of debates. And then Bharat Dave is writing about how to manage a spine center, and then you have finance. So I think we need to learn all these things because we are very poor in all these things. So I must take a fellowship course with Parag Sancheti and Shailesh. Now I have to go to Pune. It's always a pleasure to go to Pune, and it stopped since many years. So I look forward to going. With these few words, I welcome you all to this excellent evening, and I shall remain online as long as I can. So all the best and have a great interaction.
Thank you, sir. Thank you, sir, Shankar sir, for your kind words. And for last 2 years, he's handling the big portfolio of president of Association of Spine Surgeons of India, and they're doing great work socially, education-wise, and meetings. In this tough time, he was looking after in COVID. He is like a true COVID warrior from ASSI. Thank you for giving us time today. I would request our chairperson, Dr. Parag Sancheti, to say a few words. Over to you, Parag, sir.
Thank you, Dr. Shailesh. And on the outset, a very, very good evening to you on this lovely Saturday evening where we are going to discuss a lot of spine issues and non-spine issues as well. So let me first welcome the president of the Association of Spine Surgeons of India, Dr. Shankar Acharya, whom I have great respect for, and I've known him for a long time and hearing about his activities. So I think that is something which is really good, the academics he has been doing in the last 2 years. I also want to thank Dr. Vasudev Gadegone for joining us. He is the president of Maharashtra Orthopaedic Association, and very soon they will be celebrating the Maharashtra Orthopaedic Association annual conference in no other place than Goa. So I think the spine weekend has been there for a long time now. 8 years continuously is a big time for the spine to focus its activities. And even though the COVID was there last year, Dr. Shailesh did not get bogged down, and the year before last as well. And as Dr. Shankar Acharya sir said, he was in fact more enthused. Sir, let me tell you today that even though Shailesh, you think, have the support of Sancheti Hospital and mine, Ashok, Shyam sir, we will give you double support. So I really wish you come to Pune sometime. This is on a lighter note, but we would like to meet and take more inspiration from you. And we've always heard so many good things about you. I think the theme is very rightly chosen. Is the dilemma in spine, and I think in 6 hours, 3 hours today and 3 hours tomorrow, it will be important to just highlight certain dilemmas, for example, in knee arthroplasty, whether to do robotic or non-robotic, whether to use drains or not use drains, whether kinematic alignment is good or whether mechanical alignment is good. These are hot topics. So I'm sure you have your own topics, and it's always good to have a flavor of what is going on. And I think it's a process of evolution. Dilemmas always evolve till the final nail in the coffin is put. So I'm sure Shailesh has chosen the right topics. I welcome the entire faculty, and I can see many of them here: Dr. Neeraj, Dr. Samir, our alumni, Dr. Shardul, Dr. Kiran, Dr. Pramod is our own person, Dr. Siddharth, Dr. Turel, Dr. Abhishek. So welcome all of you, and also want to thank Ajay, Kothari, Pramod, Bhilare, and Siddharth Aiyer, who are strong members of our spine team under the leadership of Dr. Shailesh to take this spine weekend forward. I would just like to end by saying that next year, Shailesh, we will not allow you a virtual meeting. You're getting too used to it. So next year, it has to be a physical meeting, and we will invite the same faculty next year. And Shankar sir, you have to come next year as faculty to Pune. So with these few words, I wish this program all the best. And I'm sure at the end of this program, all of us will have something new in our knowledge so as to ultimately treat our patients better and improve their outcomes. Thank you very much.
Thank you, sir.
Thank you, Parag sir, for your really kind words and blessings to all of us. And as we all know, Parag sir is one of the pioneers for the Ranawat Orthopaedic Congress, and they are doing great show for nearly 2 decades. And this year, the Hospital for Specialized Surgery wanted spine to be a part of the ROC, the Ranawat Orthopaedic Congress. And I think Parag sir and Dr. Ranawat, they are working towards it. We will come to know about the agendas very soon, and looking forward for that as well, Parag sir. Thank you.
So this time on 19th of January, as a part of the ROC, the Hospital for Special Surgery has introduced 1 day of spine parallel with the arthroscopy session. So, I wish to invite all those here and all those who are hearing the program virtually to please join us in Mumbai at the Hotel Renaissance, now called as Hotel Westin in Powai, for a live 1 day theme. And Dr. Shailesh will be making the scientific program. So I welcome all of you for that. Thank you, Shailesh.
Thank you, sir. We move on to our next invited president, Dr. Vasudev Gadegone sir, who is working tirelessly for the academics in Maharashtra and all India. I can say everywhere, constantly, there are a lot of meetings going on, virtual and non-virtual, and Gadegone sir is personally there looking after all the small intricacies. And this year, it's a big MOA con which will be in Goa. So I invite Gadegone sir on this occasion of inauguration of Spine Weekend. Gadegone sir.
Yes. Thank you, Shailesh, for inviting me for this a very important meeting of spine updates. And I also welcome Dr. Shankar Acharya, President of the Association of Spine Surgeons of India. And the most important thing, this webinar is backed by none other than the Parag Sancheti. That is the most important thing which is should be highlighted. And it's because of the Sancheti Hospital is always a front and forerunner in all academic activities, not only in the spine, but in trauma, joint replacement, everywhere. So Sancheti Hospital has a much more presence in Maharashtra, not only in Maharashtra, but in all over India. And there is one has to acknowledge and reckon the name as a Sancheti Hospital. That means there is a Sancheti Hospital. It's synonymous with the work and the academics. And you are fortunate, Shailesh, that you are working with such a giant in orthopedic in a Pune institute. So I welcome all viewers of Maharashtra Orthopaedic Association, Indian Orthopaedic Association, as well as the viewers of OrthoTV. And Dr. Ashok Shyam has done such a wonderful job since last 2 years. Now a virtual platform which is giving and educating the all stalwarts. They are giving their knowledge to a young orthopedic and budding orthopedic surgeon. So spine is a very complicated subject and intricacies are there. There is some controversies are still, and that will continue to be there. And I hope this webinar will solve some of the queries, whether to do this surgery or that surgery or what are the controversies and how to get the patient better. So thank you very much, Parag sir, Shailesh sir, and Shankar Acharya sir. You have given me a chance to share the virtual platform here and the inaugural session. Thank you very much, and wish all faculty members will deliver their best so that something will be come out with the concrete views regarding a particular subject. Thank you very much. Thank you very much, sir.
Thank you, Gadegone sir, for your really kind words and blessings. And we move on towards Dr. Ashok Shyam for the inauguration. Yes, Ashok.
Kurutvam kalyanam arogyam dhana sampada shubham kurutvam kalyanam arogyam dhana sampada shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute shubham kurutvam kalyanam arogyam dhana sampada shubham kurutvam kalyanam arogyam dhana sampada.
Thank you, OrthoTV team, Dr. Neeraj, Bijlani, and Ashok Shyam sir, for this wonderful inauguration. And we formally announced that the program is starting. Along with the flyer, Dr. Neeraj Sonone, who is a birthday boy today, and Dr. Ajay Kothari also is a birthday boy today. We welcome all of you today. Neeraj, thank you for accepting our invite. And we start our today's session. And the session is very interesting. We will be starting with interesting cases and it will be interactive. Dr. Ranjit Unnikrishnan, who is working in Kerala, one of the stalwarts in the country, will be presenting his work, and we invite Ranjit. Will be followed by Dr. Abhishek Srivastava, who is practicing in Delhi, and they all are practicing more than 2 decades in spine. We will start with interactive cases. Then we will have 2 debates, and those are also very interesting. When I should fuse and whether I should fix it. That's the first debate, and the second debate also is very, very interesting. So we'll come across. I would invite Dr. Ranjit Unnikrishnan to start the shot. Ranjit, over to you.
Thank you very much, Dr. Shailesh and the august audience, Shankar and the faculty. So it's a very interesting concept. So shall I share my screen?
Yeah.
Okay. Are you able to see my screen, Shailesh?
Yes.
Perfect. Okay. So a very, very innovative concept, the good, bad, and the ugly. So I'll take you through one of my mistakes, and let's see what how our faculty will help us solve the problem. So this was a 26-year-old female who had back and leg pain and fever for 2 days, no weight loss. And she had an MRI done for 2 days of fever and leg pain and was diagnosed with TB spine. And she was started on ATT, 4 drugs. And after 1 month of ATT, she developed weakness into the ATT and bed rest. She presented after 3 months of ATT to us with bedridden status. Lower limb grade was 0. upper limb was grade 5. She had no pressure source and she had no bowel bladder incontinence. This was the X-ray at presentation. So this was after 3 months of ATT, empirical ATT, for suspected TB spine MRI done. And this was the MRI. So when she presented, grade 0 power, no pressure source. So let me have the opinion of our panel, Dr. Abhishek, let me ask you, what will be your solution at this time, at this juncture?
Well, I think, first of all, we have to establish diagnosis, what is going on.
Okay.
I mean, there are multiple lesions in the spine. It could be a diffuse, TB, or it could be a pediatric, malignancy also it could be. So we have to be sure what we are dealing with. So I think biopsy is something which will be needed.
Okay. So Dr. Neeraj, happy birthday.
Yeah,
Next over that. So with this lesion, such an extensive disease right from C2 to sacrum with dense deficit to significant site of cord compression on ATT since 3 months, started deficit after ATT of 1 month. What would you want to do? Do you want to just take a biopsy and establish diagnosis, or what would you do? With the relevant CTs and the MRI cuts.
Yes, your question is absolutely perfect. There are 2-level compression and the patient is having non-functional or a grade 0 power. I think this is a emergency situation for us. I would like to go in there, decompress the cord and take a good sample from there itself. So posterior decompression, I will try to do a lot of anterior job. I think the spine alignment still is acceptable. I will just go all posterior, take a good biopsy and decompress the cord from posterior.
So which all level will you do? Will you do the upper thoracic and the thoracolumbar junction, or only the thoracolumbar junction, or only the upper one, or both?
I will like to tackle both at a time.
Both at the same time.
Yeah.
So what would be a solution for both of them? So if you look at the CT, there is significant anterior vertebral body loss.
Yes.
So there is VBL loss of more than 1 level in the thoracolumbar region, as well as in the upper thoracic region.
Right.
So do you think, Shailesh, do you think that just a back job will be able to do the entire thing, or you will want to do front and back or back to front?
I think, means it is always a challenging thing, and a young patient, you can always think of, because in TB, there is significant amount of weight loss or things looking at this MRI, that patient must be suffering for a long time, and it's like last
3 months.
present. Yeah. And she presented to us. So I will personally prefer a posterior job in this particular case. I will not rush for an anterior surgery. We can actually do very good anterior reconstruction if we want to in these kind of situations from all posterior.
Yeah, Samir, don't you think so that for this kind of a picture with extensive vertebral body involvement, 2-level surgery needing front and back, with going to be having very poor hold of implant, are you worried about implant failure or too long a surgery? Will she be able to tolerate it? Samir?
Definitely, sir. So these are the there are numerous complications that can arise when we are contemplating this surgery, like implant failures and long duration of surgeries with blood loss, and all these have to be counseled. But considering that the patient is having power loss, I think the risk needs to be taken.
And you will definitely agree with what Dr. Neeraj and Dr. Shailesh said. You will want to do both at the same setting.
Yes, sir. Both at the same setting. Front and back. Yes, sir.
We have a neurosurgeon, Dr. Mazda Turel. Are you there, Mazda?
I think Mazda is here.
Hi.
Yeah, hi.
Hi.
So let's see. Let's see a lateral approach from a neurosurgeon. Let's see.
I would like to ascertain the neurology. Whether the is the lower limb paraplegia, is it a spastic paraplegia or is it a flaccid paraplegia? Is there any sensory level?
There is So it's a flaccid paraplegia. There is no sensory involvement. She has got intact sensations. Bowel bladder is preserved. Only has motor grade 0 power. Upper limb is normal, 5/5.
And sensations are absolutely preserved.
That's right. Pure motor.
So probably if you go by the neurology, it's possible that her deficit is arising from the lower lesion rather than the upper lesion.
Okay.
And if she's been in this particular situation for the last 1 month, rushing into surgery the next day is not going to really change the outcome. If it's possible,
it's been 3 months since she's like this, and she's been on ATT.
Correct. Do you have an image? You won't have an image on the basis of which they started the ATT, correct?
I don't have an image because this is the image which I didn't inherit an image from her.
Yes.
Because, this is the image which I have when she presented to me.
It's pretty straightforward to get a diagnosis either with an ultrasound guided biopsy. The lesions pretty superficial posteriorly in the midst.
Yeah, but then if you get an ultrasound guided biopsy, she says tuberculosis. Are you not going to operate her?
But I would still like to have a biopsy, because biopsy, if it is tubercular, that is good enough. Then we have.
Fine. So it's a biopsy is tubercular. So what further now?
Then you have to go and decompress. Then
that's right. So exactly like what Neeraj mentioned, my rationale was that again, she's on ATT for 3 months. The MRI is suggestive of spondylodiscitis. If it is tuberculosis, what's on 3 months of ATT? So yes, Neeraj, please go.
Ranjit, irrespective of the etiology, whether it be a fungal, whether it be a tuberculosis, whether it's a metastasis or primary, we have to go and decompress the cord as soon as possible.
No.
I think is the same for most of the stuff.
I mean,
the etiology. Yeah.
I think Abhishek disagrees. He wants a tissue diagnosis first.
No, I totally agree with Neeraj that it is an emergency. If there is an acute paraplegia, say within 24 or 48 hours, then there is a need to rush in as soon as possible. But if it is there for more than 3 months or 1.5 months, 1 day of difference is not going to make much of a difference. So I think the time of paraplegia has got a bearing. So then we have time at our hand to establish a diagnosis and then contemplate a procedure and not to do anything in rush. This is not.
I think the question of Ranjit is most likely this is tuberculosis because they have already given 3 months of AKT. Chances of we getting the bug culture are very, very less because already patient is on AKT. So that's also, and if it comes out to be a tuberculosis, anyway, patient is on medicines and he's lost the power. So why to wait for 5 more days? Just give the best chance. I think, is it right, Ranjit?
Yeah, perfect. So that was my rationale. Anyway, she was on all these things for months together. She still, I had my own concern, like, I really wanted to do front and back both at the same sitting, but I had my concern about this, having hold of screws, etc., plus cervical lesion being there with no cord compression. Anyway, like all of you suggested, I went ahead, did the front and back, both levels, same sitting, right? So, like, I think what all of us would do, I did it. Any critical comments, Neeraj or Shailesh, at this? Is my cage wrong? My screws wrong or anything here?
No, it looks perfect from my side. Just in such cases, I will like to add a posterior sublaminar wires because the posterior bone is relatively healthy. That's it. And otherwise, it looks quite perfect for me.
Yeah. Good job. Dr. Abhishek, any thing wrong in my fiction or anything to add, or am I short? Am I wrong?
No, it's been done by you. How could it be wrong?
No.
Wrong is too a strong word.
Yeah.
I think we can just add our own, touch to what's there. I would have instrumented a bit long, but I think you have done the job very well.
So instrumented long in the upper thoracic spine or the thoracolumbar region? I
think upper thoracic, I would have gone a bit more.
You mean for the upper?
No. For the thoracolumbar, I would have gone slightly one level thoracic as well.
Yeah, or the screw can be slightly longer.
Okay. Yeah. At the index level, you mean the defect level?
Yeah.
Okay. Let's hear from Shardul. Shardul, are you there? Dr. Soman?
I'm there, sir.
Yeah. What is your opinion? You and Dr. Bhilare, Pramod. Yeah.
Yeah, I think the surgery done is quite acceptable and reasonable enough. I think this is enough, especially with the anterior reconstruction. I don't think more longer segment fusion is required, and especially with tuberculosis or whatever infection is, I think if it turns out to be some other infection than tuberculosis, we don't know, like in fungus, we don't know how the instrumentation reacts to it.
You're taking the graft also, iliac bone graft, we can see that.
Yeah, I used copious amount of graft because this being tuberculosis and huge defect, I filled the cage with graft, and I also needed cage. I used a bit of the rib which I knocked off to go to the front to fill the upper thoracic cage. So this is what I had at that point of time.
One thing which goes with you is that you have done a very good anterior reconstruction. Therefore, maybe we can accept
I thought I did a good anterior reconstruction. So as it would have it, so the histopathology came out with tuberculosis. Gene expert was positive. It was not multi-drug resistant tuberculosis. It was drug sensitive. We continued ATT as per weight. She regained her motor power completely and became a walker ambulance at 3 months post-op. And the lower limb was still spastic. It was flaccid, turned out spastic, but she could walk with the spastic legs. So this was at 3 months post-op. There comes the picture. So Dr. Samir, what should you do now? Samir Rupare.
Yes, so I think the implants have loosened out, the screws have loosened out, and the construct is failing. So I will probably go in and extend the fixation above and below, and put larger screws, bigger screws with larger diameters.
How many levels will you go, Samir?
At least 3 levels up and down. Sir.
Okay, so Samir, at this point of time, at 3 months post-op, when patient is walking and gained her power, you would want to go in and revise at this point in time because you expect this to fail.
Yes, sir. Yes,
right?
I think one of the rods is almost protruding out of the skin, if I'm not very sure.
So you feel that I was wrong in my judgment that with this kind of MRI, with having such amount of soft bones, I should have gone more longer, like what Dr. mentioned, right?
Yes.
I should have got more longer, and I should have, anyway, the cage was there, the screw was there, and I should have put thicker screws. This was, by the way, 6.5 screws, not the 5.5, the 6.5 screws. So I should have gone longer, right? Okay. So Neeraj, at this point of time, at 3 months, would you choose to wait or would you like to go in?
I think there is no point in waiting for this because this is the spine is slightly unstable. Though we have faced similar scenario, and if the implant is failing, we have to intervene even if the neurology is intact.
So I did suggest at that point of time because the family was extremely skeptical because they were very glad that the child is walking, the girl is walking. She was just married 1 month after marriage, so it was a very very tenacious situation.
Yeah.
So I told him, well, now you will go to fail. Please let us revise. They told, no, sir, if he's walking, we want to wait. So this was
Sanjit, my another question is, sorry to interrupt. Though patient is sensitive to all the AKD drugs, she was taking AKD since last 3 months. How she from zero, she normal, she become grade 0 neurology?
That is the good.
That is why
we wanted a biopsy and why it was failing.
But at the end of the biopsy, he got the same thing. No?
Yeah.
That is nothing different what we were expecting.
Yeah.
So, but paradoxical reaction in a case of tuberculous spine is a known entity. In spite of giving AKT for the initial couple of months to 3 months, there will be an increase in the progression of the destruction and the abscess formation, and later on it starts declining. That's the reason we don't take 3 months.
The question was that when this lady developed paraplegia after 1 month of ATT, I don't know, was it a good decision to sit on it for another 2 months more?
Yeah. So I agree.
That I totally agree.
A paradoxical reaction can cause worsening of symptoms and imaging.
Yes.
Even if you have deficit, you give steroids, it doesn't improve, you go in and decompress, right? You don't sit on it.
Yes.
So this was, for whatever reason, this was it. For want of time, we'll go ahead. So this was the thing which I told, well, though they waited, it came to 12 months. So this is at 1 year since surgery. Patient totally regained power, became independent ambulator. No walker, nothing. Mildly spastic, still walking, regained everything back. And this was the CT at 1 year post-op. So Neeraj, would you want to wait? She has no pain, nothing. It is just a bit of the screw jutting out there to the skin. There is no wound.
So just let the screw in, revise on the similar track, go in and give a good anchorage.
Right.
If
So
C2 is also fine. Just I think the implant has to be revised.
Yeah. Do you want to do anything for the anterior cage? Pull it out, take it out, push it back, change it?
I think there is an attempt of healing there. If it was not fused or not healed anteriorly, it would have been failed by now. Or it have gone worsen than the...
the X-ray is very clearly showing that the cage is moving into the canal, right? If you see serial X-rays.
Gradually movement.
Right? It's going into the canal, right?
Yeah, in that case, I will like to revise the anterior fusion also.
Exactly. So the going in for a already done Leica approach and reviewing the cage, I've had very serious bad experiences. So I did contemplate that and thought, well, we'll plan for revision. At this point of time, they were still skeptical. I told that, see, if you have this now, this X-ray, actually kick them off. I told, look at this, serially, it's going into the canal. Now you'll end up with a paraplegia. At which point of time, they agreed for a revision. Right. So there I planned ahead. So I'll just, we don't have time for all this. So just very interesting. So when at that point of time, I went ahead and looked up, spinal pseudoarthrosis, how you can really pick it up, because I was very clear that the X-rays is the X-ray showing that is pseudoarthrosis, but how can I really prove it with no pain that the patient should be revised? Then looked up all these features which say that, different modalities, different things have got different way of sensitivity and specificity. And this one increasing thing that after there is an increase in the fusion rate as time progresses. And if you look at dynamic X-rays, I was surprised to know that there is less than about 3 mm of translation is normal in a dynamic X-ray in lumbar fusion. So when it is more than 4.1 is something when you consider it as pseudoarthrosis. That is new to me. Then I went up and looked up my own pseudos, how they did. Now this patient, we went ahead, we did so again, in this, it is very clear that...
Give me some surprise.
Sorry?
Give me some surprise and some learning point.
If you see, Ranjit, the cage is, it is collapsed and cage is translated a bit on the left side also.
Yes. So for me, I think the pathology was tuberculosis, which I and you knew. It was on right medical management. I had enough grafts and cage. My construct instability was like what you all pointed out. I should have gone much more longer. I used Lopez grafts. So I don't know, would I have something else to add to the osteogenicity? So at this point of time, I went ahead, I did a revision, right? I went ahead, I went longer as we all discussed. I went with thicker screws. I went to 7, I think 7.7 or 7.5, went longer. And I planned to punch in or move. When I found that the cage is actually rock solid. It is more of angular mobility happening at the pseudo site, nothing really into the cage. So I chose to just leave the thing there. And this was after, this after the revision. And this is after 1 year after her second surgery. So she went out to heal uneventfully, and I got a follow-up on her for almost 1 year after the second surgery. So that was it. Interesting thing was that local ortho bone graft and ceramics, that is HAP, have got similar fusion rates in lumbar fusion. Mind you, lumbar fusion. So there's absolutely nothing wrong in using hydroxyapatite or all those things when you try to augment your fusion other than using BMP and all those, right?
Okay. Thank you.
Thank you, Neeraj, and thank you, Shailesh.
Thank you, Ranjit, for a wonderful case. Is Shankar sir around? Hello, Acharya?
I think sir is...
I think Mihir is joined. Hi, Mihir.
Hello, sir.
Mihir, your mic is muted.
Of course, I'm muted because I missed the case.
Okay, welcome, Mihir. And I think it was a wonderful case, very, very interesting, and all points taken, because, retrospectively, we always think I should have done this or that, but that is what is learning. And each case is different. If you realize all the bone stock, everything becomes very soft in TB spine. We try to, in a young patient, we try to avoid long segment because it is at thoracic and lumbar. We try to save some levels, and that is where the learning comes. Sometimes we can go wrong. If you fix long also, it would have failed at the proximal or distal level because we don't know how the TB is behaving, how the medications are behaving. And it was a beautifully executed case, and she's walking. That's the great thing, Ranjit. I must thank you for sharing this interesting one. And we move on to the next one. I invite Dr. Abhishek Srivastav from Delhi, one of the eminent spine surgeon from Delhi, and he's into the ASSI Education Committee, looking after all the fellowship programs. Over to you, Abhishek, for the second interesting one, the good, bad, and ugly.
Okay, so I have to share screen.
Yeah.
Okay. So, okay, first of all, let me thank the organizers and the Sancheti Hospital for giving me this opportunity to present this case at the Spine Weekend, the 8th edition. So the case I have chosen today for my good, bad, and ugly probably will help you learn something. I mean, I learned a lot from this case, so hopefully it might be of help to other people also. So, so the story begins. So basically, it's a story. It was way back in 2013. It was a Friday, and I was contemplating. I mean, the place where I worked, Saturday and Sunday was off. So I had a lot of plans for my weekend. And so something like this was, running through my head. And I had planned which were long in waiting. But suddenly you have this nasty phone call. And there is a 30-year-old male patient presented in ED with inability to walk. History of acute left arm paresthesia with left leg weakness. Power was 3/5 in L2, L3, 3/4 in L4, L5, whereas in S1 it was 4/5. Right power was normal, altered sensation. The ED guys had been holding that patient since morning, and they decided the apt time when I was about to leave to call me up and to take care of the patient. So they had ruled out CVA. So then I ordered for an MRI scan based on the examination. And this is what we got. It was a huge disc at C6, C7, as you can see here, which is nearly occluding the canal. So any thoughts, Shailesh?
No, I think if the patient is presenting with such an acute disc with weakness, motor weakness, is there a whole spine screening also?
No, not. I don't have the images here for that.
But nothing was there.
Nothing was there. I screened the thoracic spine also because the presentation was a bit weird because upper limb was normal. And so there was no lesion below that.
Okay. And the weakness was in the lower limbs.
Weakness was in the lower limbs. The upper limb was normal. There was some paresthesia in the upper limb.
Yeah, means I have some experiences and somewhere I have seen a lot of time you have a problem in cervical spine and patient can have unilateral weakness or monoplegia also, and it has been reported. So there is a possibility this is an acute disc, and that could be the thing probably we need to consider intervening this. And if other things are ruled out like whole spine screening and maybe brain screening, so I think this looks like the culprit.
No, but I think, can I interrupt a little bit?
Yes, Mir.
I missed that there were UMN signs, right?
Yes.
Upper limbs and lower limbs.
Yes.
So, though the upper limbs were normal, UMN signs were present.
Yes.
Okay.
So,
yeah.
Okay.
So, I think you can proceed.
Okay. So I think when I finally got the MRI report and the films, it was late at night, say about around 1 a.m. in the morning. So how many people on the forum would go in straight away, or how many will wait till the morning?
Abhishek, there might be some component of PLL. I don't know at C6 ossification. I am not sure about that. The PLL looks quite slightly thickened to me. So I will also like to get a CT scan.
Yeah, I mean, that is a valid suggestion. But I mean, I had discussion with the radiologist. He didn't think that it was PLL at that point of time.
Okay.
So we didn't get CT, and especially if you are working in a developed world, it's very difficult to get a CT scan for anybody. You have to give a lot of justification because there are concerns for radiation and things like that. And especially overnight, it's a difficult task.
Okay.
Unless it is trauma. So that is why emergency MRI was possible. That too also with a lot of, push and pull. And that is what we got. So any opinion on when to intervene? Will somebody like to go at 3 a.m. in the morning and anybody would like to wait till the morning? So
no, I would always wait. There's no point going in at 3 a.m. in the morning. Cervical myelopathy is never a dire emergency of sorts. The weakness sets in and remains stable. So you can always have a planned surgery.
Yeah. So I think I agree with Dr. Meher. So that is what I did. I thought there was no point rushing in the middle of the night because by the time you arrange everything, it will already be 4 a.m. when the incision is being done. Everybody is tired. The team is tired. You don't have your usual team. And this was a big chap, as you can see from the fact collection. It was low down. So the access was also not that easy and it was not an easy surgery. So I decided that I'll go in the morning. So morning, first case on the list, and this was the impression. But next morning when I went to review him, till 6 a.m. the neurology was the same, but after that it dropped and he started developing symptoms on the right leg also.
Abhishek, there is another compression component at the T1, T2
lower
level.
T1, T2.
We should have done axial cuts at that level also.
Yeah. So I have deliberately put that scan because that is what confounded me. But then when I looked at the axial scans, I don't have the axial. Actually, it's a 10-year-old case nearly.
Okay.
So I looked at the bottom, but it is not compressing the central part. It was on the very lateral. So that cut was very lateral. The disc was so huge. That's why I put in two sections, that from the middle right up to the lateral section, it was all there. It is not that it was only seen in one cut. So the disc was like cauda equina of cervical cord. So there was no significant compression anywhere below, which could attribute to that problem.
The whole spine screening is clear otherwise.
Yeah. Otherwise, it was clear. So still the patient did not have any deficit in the upper limb. It was the lower limb which were deteriorating. And the pins and needles were there. So then I did an ACDF next morning. Uneventful, no extension was done. I was very careful not to extend too much. MAP was maintained stable throughout the surgery. I was able to retrieve 3 disc fragments under microscope and PLL excision was done, good hemostasis, whatever I could do. But the story gets a twist and the patient wakes up with paraplegia. So these were the neurological findings, that he said that sensations have improved in the leg. Paresthesia was better, but the legs were gone completely and he could not move it at all. Catheter tug was present. So now what do we do?
So what you found intra-op different, the disc was like a normal disc, your decompression process throughout the surgery was...
Yeah, everything was stable, nothing overt happened. It was just a difficult access.
And you got a full fragment, what was...
3 fragments, I was 3 big fragments.
Dr. Abhishek, was it a soft disc? Sorry.
It was a soft disc. It was a soft disc. Dr. Kiran, it was a soft disc.
No, I think the first step now is to first get an MRI. I think to see what is happening.
So that is what I waited. I thought patient is still under anesthesia. So I waited for another 2 or 3 hours. I did one more procedure in between from emergency. And then I came back and reviewed. So at the end of 3 hours, there was no change in the neurology. So then I asked for an urgent scan. So this is what was done. And this is what we could see on the scan. MRI revealed that the fragment which was there has been removed, but the canal was constitutionally narrow at that level. And then there was this edema which was going up and down. It was completely white, bright looking cord, one level up, one level down.
Yeah, so I think right now the spinal, there is a state of spinal shock. And this is like a trauma on a spondylotic canal. And that trauma could have been a minimal handling, which also can set off spinal cord edema. So at this point, you just have to wait and watch. So you have to give patients some time to recover from this, and there is no real urgency of doing a posterior procedure at this point.
Yes, Abhishek, but still I think what I was worried about the PLL, it still looked thick, and I am not able to appreciate any hematoma or edema compressing the cord.
So we have an
Neeraj, can I just ask Abhishek a question? Sandeep here. Sandeep here.
Yeah. Hi, Sandeep. How are you?
Hi. So I just followed a case, joined a case just late. I really am thinking whether this is a vascular in origin, because if there's an sort of anterior spinal artery compression, because the symptoms to begin with were not very convincing. The patient is having lower limb weakness only on one side. Later on he develops the weakness on the other side. So I'm not really convinced that this is purely because of mechanical compression. This could also have a vascular origin.
Agree.
Mazda is asking how much was the blood pressure through the operation.
So so the map was more than 90 during the procedure. I mean, I deliberately kept it above 90 because in myelopathy, I try to keep it above 80 and 90 because that is where, if there is any episode of hypotension. So we went back and we looked at the whole chart also, if there was any episode of hypotension during the surgery or anything like that. Because I was really perplexed. I wanted to know why it had happened to me. And this was one of my, earlier years of practice and one of the first cases in which I had a deficit. So I was really shitting in my, pants at that point of time that what has happened.
So I think.
Yes, what was the status of the pain and temperature sensation?
The difference is that.
So I think the pain was better, but the temperature I did not check.
Pre-operatively, pain and temperature in the lower limbs.
So I have not checked for temperature, but definitely pain was better after the surgery.
See, what theoretically, if you want to put it, the patient presented with an anterior cord syndrome. Okay, so it was lower limbs more than the upper limbs to begin with. And the patient is still an anterior cord syndrome. So an anterior cord syndrome where basically the tract to the lower limbs are affected. It's not a pincer effect on the cord. So that means that the patient has had a cord edema, which either could have been set off because there was a large disc which you have just removed. Even though there was a minimal handling, the spinal cord can still get a cord edema, which is a very, very known kind of a thing in a stenotic canal. So at this point, the cord is stenotic and it is hurt. So the question is, do you want to intervene or do you want to wait? These are the two questions which need to be answered. The only difference is that in India, we would do a CT scan because we see innocuous OPLLs behind the body in quite a few instances where the canal has been narrowed and you are extra cautious about these cases.
Yeah.
Unfortunately, a CT scan has not been done. So now the question is, in the present situation, do you want to wait or do you want to intervene?
Yes. So how many people would like to wait?
I would like to wait.
Okay.
No, I won't, sir, because see, we are not going to worsen than this at present. The cord is absolutely not function below that level. There is no chance of decompression. Go push and do a full job.
I feel if it is something like a vascular, like an anterior spinal sort of selective syndrome, if you intervene, you are going to give more sort of a surgical trauma to this patient. So should not. I don't think it's
no, sir. Sandeep sir. Still there is a compression component present. The vascular thing we can't pick up through a MRI or through our theories. Okay, it's the compression still we can see there, and the cord has absolutely been damaged.
Anyway, so what I did,
I think no chance in going there, sir.
Yeah. So what I did, because I think it's a good idea to have a second opinion. So I called a colleague and I told him the whole situation. And also I called the neurologist because there was discrepancy in the neurology from the beginning. So we had a long discussion, with the radiologist, neurologist and the other. And so these were the differential diagnoses. I think most of the things have been covered already. First was cord perfusion injury. Then there was persistent compression. Then there is anterior cord infarct, as as Dr. Sonone has identified. Then new onset of compression secondary to post-surgical edema or hematoma. So hematoma was not there. There was no way in which we could identify cord reperfusion injury. And the radiologist said that the fragment has been removed, but because the canal is narrow and there is some amount of thickening behind the vertebral body, so there might be some persistent compression, but it is not, it is much better than what it was before. So the consensus was, after discussion, was that we are going to go back again and do a, posterior surgery, giving the cord best chance to recover. However, we had a long discussion with anesthetists whether they are comfortable taking the patient for another procedure and should be able to maintain the blood pressure at a reasonable level, because if it is a vascular injury, you fiddle too much. So he said you have to do it quickly and safely, and we don't have much time, because if we do prolong the surgery, then again the chances of further injury to cord are there. So same day I went ahead and I did C5 to C7, posterior instrumentation and laminectomy. The cord was swollen and inflamed when we did it. So this is the post-op of second surgery. And the end was that immediate post-surgery 0/5 again when I went back and checked it, but the sensation was intact and preserved perianal and contraction. Next morning, there were flickers in EHL and ankle, and 48 hours, patient was moving legs. 2 months, he was fully recovered. 3 months, joined back to work. And 9 months follow-up, when I came back from England, I had a follow-up, and, he was fully fine and recovered completely. So I still wasn't sure whether I should have done, because when we discussed in the morning meeting, like Dr. Mihir said, some people said that we wanted to wait out. It was a reperfusion injury. Some said, no, it was a good idea. But at that point of time, I felt lost. There was nothing to guide me with that conviction that, I could sit over it and wait. So I think Dr. Mihir might be, right, based on his experience. But it was my few early years and I didn't want to leave anything to chance. So that was the reason.
No, I think Abhishek, a credit to you is that as a surgeon, if you have owned up to the deficit and if you have found a compressive element and if you have decompressed and the patient has recovered, there's a full credit given to the surgery. That means the surgery has effected a cure. Now the question is, endlessly we can debate whether it was reperfusion or whether it is whatever. But finally what you did made the patient walk. And really whether it was the spinal shock that ended at 24 hours or whether it is the decompression effect that helped, no matter what, the patient recovered. It was a difficult situation. So hats off.
Right. Well, good job, Abhishek. And I must applaud you for this good work and braveheart second attempt.
No, but so basically this is the cascade of events which happens in reperfusion injury. You do decompression, there is restoration of blood flow, altered blood-brain barrier, free radical injury, and these are the things. But the story doesn't end here. This was the first part.
Okay.
Fantastic.
Yeah, we are waiting.
So this was the final diagnosis which we thought that it is, but and I thought that the nightmare had ended. So I went through it and I published it as well, so that other people can benefit from it. The debate which we are having right now, and it is in European Spine Journal. If you want, you can read it there. But then again, 1 year back, I had a similar case, 51-year-old male presented with gait instability, inability to walk since one day, suddenly, neck pain with radicular pain off and on. This was the neurology, as you can see on examination, and he was not able to walk. So again, I thought it is deja vu. And I was really scared that this time also, things are going to go that way. So this is what, came to my mind. That, not again. I should not go through that pain again. But then, I went ahead. This is the scan. As you can see, it is a large disc there, right? And this time I had the, liberty of getting a CT scan done, as Neeraj has said, and as you can see, the posterior vertebral wall is thickened here. So this was a sort of a calcification because the normal wall is just, a thin sliver of cortical bone. But again, it was an acute disc. There was nothing behind. So I went ahead and did an ACDF, C6, C7, against the same level. and post-surgery, paraplegia with intact sensation again. And but this time, I had told the patient that this might happen. So don't lose your, hope after the surgery, because history doesn't repeat itself, but it does rhyme. So patient was unable to move his legs for 4 hours, but with preserved sensation, I stuck out, gave steroid loading dose, shifted to ICU, MAP was maintained, flat bed rest. But after 6 hours, patient started moving his knees. When you flex his knees, he was able to extend it. And over next 36 hours, regained full power. And patient was walking after 3 weeks and no deficit at 2 months and final follow-up at 1 year. This time, I did not do any posterior surgery due to my previous experience. So if I had thought if the patient will not recover for more than 6 to 8 hours, I'll go ahead and do it. But, it started showing recovery. So this is 1 year post-op. And this is just MRI, which was the post-op MRI compared to the pre-op MRI, which was done today only. So I thought it will be a good learning lesson for everyone.
So Abhishek, first case you felt that I was right, and second case I thought I am wrong. So
No, no, it is just, I think it was always...
Well done job, Abhishek, and a lot of learnings from this. As Mir was saying, you can, if you wait, probably you would have gotten better, but you did a right thing, because ultimately that is what the winner is, when you really do a right thing at a right time. And I think both cases you nailed it very right. Thank you for sharing these wonderful cases, and because of short of time, we'll have to proceed further. Thank you, Abhishek, and we invite Dr. Mazda Turel. Thank you. Dr. Mazda Turel, he's a neurosurgeon, and he is currently working at Bombay Hospital as a neurospine surgeon. And we want, because this webinar and the conclave is mainly for benefit of all, and what he has learned over the period of time in his fellowship, and that is what the important topic which we thought of sharing. And over to you, Mazda, and thank you for accepting this.
Hi. Am I audible and visible?
Yes.
Okay, great. Thanks for having me for this wonderful. The first session was really exciting. Before you started the second case, I was just going to ask you, would you do the same thing if you had a similar patient in the future? And then you went ahead and showed that beautiful case. No, it's very unnerving for any surgeon to be patient rather than do something. But sometimes doing less is actually doing more, is what we learn over the years. So I'm going to just briefly take you through a journey of what I learned in my fellowships. And this may seem very amateur considering the stalwarts that are present. So please pardon me if it sounds very basic. I did my grant MBBS at JJ, and then went on to do neurosurgery at the Christian Medical College in Vellore. And we had a fair mix of exposure to brain and spine. But then I wanted to specialize in a little bit of both. So I went and did a neuro-oncology fellowship at the Toronto Western Hospital. And the beauty about these places is that they also have a huge department of neurosurgery, where they have a very strong spine center headed by Michael Failings and his team. So I got a chance to see a lot of the spine places as well, and interact with them. And the focus at Toronto Western Hospital in some sections is a lot on outpatient neurosurgery. So we did a lot of brain tumors that got admitted on the day of surgery in the morning and were discharged in the evening. And I learned protocols for outpatient ACDF, for lumbar spine cases, for T-lifts, all of those that were managed very, very brilliantly. And the beauty about, even though you may not technically learn too many things differently when you go abroad, you get to meet people, you get to interact with them, you get to understand and analyze their way of thinking, which is what makes the experience very wholesome. You get to meet all these people who you actually only have read about in textbooks and read their publications and papers, and you see how they actually function. How do they make teams is very essential. Here in India, in Bombay, we try at least in the private practice setup, try to do everything solo. I more and more realize that the more we collaborate, the more we have people with us, we have more heads trying to identify a single problem, and then that's great. And they really celebrate every little thing. You know, they have a big get together for the inauguration, for starting a fellowship, for finishing a fellowship when someone else joins. So there's a lot of bohemian interaction with the team. And then I went and did a spine fellowship in Chicago at the Rush University Medical Center, which is a fabulous looking hospital situated in Midtown Chicago. And you can see downtown Chicago. And this is the view from the operation theater. So we operated at all times of the day. And I made it a point to take a photograph of the city. It really looks majestic. This is in the monsoons. This is on a bright, sunny summer day. And this is when Chicago is overcast with clouds. It's a beautiful city. And I trained with some great stalwarts. On the right is Harold Dooch, and next to him is Richard Fessler, who's probably the pioneer of minimally invasive surgery. And next to me on the other side is Vincent Tronellis, who I don't know if you've heard, but when he was a resident, proposed the classification of occipito-atlantal instability. You must have all heard of the Tronellis classification. And next to him is John O'Toole, who is one of the editors of Journal of Neurosurgery spine section. So the way our fellowship was formatted is that I spent 3 months with Vincent Tronellis, who does only cervical spine surgery. That's it. Only cervical spine surgery. And then there was another doctor called Dr. O'Toole, who did only spinal tumors. So we spent 3 months there. And then I spent 3 months with a doctor doing adult degenerative deformity. And then I spent 3 months with Fessler doing everything minimally invasive. So, we've specialized to a point where in India, where people do either brain or spine, as far as the neurosurgeons go, as far as the orthopedic surgeons go, they do either spine or joints, etc. So their specialization of spine goes to the next level. I mean, a cervical spine guy won't touch a lumbar spine problem. One person is solely dedicated to spinal tumors. And that's what makes their work very interesting, very detailed, and very, very educative. I mean, this was my first day in the OPD. And you can see, I was seeing some patients. This guy came in walking. They never really stopped fusing patients over there. He started off, I was told 15 years ago or 20 years ago, with a single level T-lift. And then slowly went up all the way. He's got a C2 to C4, C7 ACDF, and then only thing left is an occipito-cervical fusion. So, what the thing is that these guys want to continue to improve the quality of life of patients. And the mindset in India is not very different. But, if there is a failure, they will continue to rescue these cases. And they keep getting failures and they keep rescuing. And that is how, and obviously something like this has a dual mindset. Some people will agree with it, some people won't. So I saw and learned many, many things. This was about 7 years ago. At 2015, I returned. I didn't agree with a lot of the things they did, but they were all very open to discussions. Like, they used to have a tendency to fuse all black discs, degenerative discs, with severe back pain, with no radicular pain. And I said, we've never followed this protocol. And they showed me several patients who they've done this operation in, and with exceedingly good results. So, you get to change your point of view. You get to discuss what you've learned with them. And there was an excellent, at Rush, there was a very good neuro-ortho collaboration. There was a very, very strong orthopedic spine team as well. And every Friday, we used to have a joint meeting. And there was no bad blood between anybody. And the discussions like we have over here in Bombay and India, I'm really proud to say that the orthopedic spine community, especially in Bombay, is extremely welcoming of the neurosurgeons. And I'm very humbled and honored to be a part of that team. So this is a standard operation. This is the commonest operation on the cervical spine that I perform. But over there, the focus is very, very strongly on cervical arthroplasty. They try and preserve motion. And we studied a lot of these compared to ACDF over long-term rates. And there is some merit in proposing a cervical arthroplasty in a select group of patients that fulfills the inclusion criteria. But this is more or less the standard operation on the cervical spine that's performed. When I trained with Vincent Trenelis, we used to do 360s, we used to do 540s. 540s means you release the back, then go in front, then fuse the front, and then you go back and then fuse the back. So a C2 to T2 decompression and fusion was standard, plus or minus a C2 to C7 ACDF. And they have a very, very extensive, rigorous evaluation of patients. And that's because they have less patients and they have much more staff that is assigned to do all of this. There's a great emphasis on quality of life, and that is how they're able to publish all these papers. So every patient gets this whole workup of, SF36 and all the other scores besides the standard VAS. And they do all the inventories. They do extensive, they do an MRI and CT scan for every patient, and then and additional investigations for patients that are required. The things that the surgeon really primarily doesn't get involved. It's the physician assistant, it's the entire team that does all this background work, and they all have a research wing for them to do this. This is the first time I saw a Jackson table where they can, do a 360-degree operation on the same patient without actually having to transfer the patient from the bed to the trolley and the bed again. I had never seen one. I'm sure it's commonly present in India today, but 7, 8 years ago, I hadn't seen a Jackson table, and they can flip the patient 360 degrees on this table. And you get a lot of these elderly gentlemen. This is a guy who had a fall and came in with quadriparesis. You can barely see his C2. Imagine trying to see anything else. He can't put his neck down. And this was his CT scan. He had AS with a complex 3-column fracture. And this is his CT scan with his neck upright. It's not put the other way around to fit the screen. So you can imagine the deformity that he had in his cervical spine. He had to be intubated in the sitting position. And then we tried to position him prone to do the surgery, but we could not. And I learned for the first time that we can do a cervico-thoracic fusion in a sitting position as well. And that is what we did. You can see how his chin is completely fused to his chest. And there was no kind of reduction or release under anesthesia. But we did multiple osteotomies and fused him posteriorly from C3 to T2. And you can see the difference intraoperatively, the reduction that we could achieve. And you can see, if you look closely, the SIOR that is so strongly present. And we've seen a couple of patients who've come with fixed flexion neck deformities with actually the clavicle visible because they've not been able to lift their head up for months. I also learned several spine procedures that could be performed sitting, especially one of these posterior cervical foraminotomies. I had never seen cervical pedicle screws till about 6-7 years ago. And they use them sometimes routinely or sometimes as a salvage procedure. And the beauty is that when you're a spine fellow, you get to work directly with the attending. And so you do one side of the case and they do the other side. So the exposure that you get is quite fantastic. And Dr. Trenelis was a pioneer in CV junction surgery. So he's devised his own machine-made cervical autographs that they put in the facet joint. And they also use these same autographs when they perform a standard C3 to 6 laminectomy and fusion within the facet joints. If you jam these autographs, which are bone, which are cancellous bone, they significantly enhance the stability of the fusion. Whether it's required or not is debatable, but the biomechanical strength of that construct is much greater, is what we did in a few studies. And so when these guys do their stuff, they do every single surgery in the same way. And they follow the exact same steps, whether you're putting a cervical screw or a thoracic screw. There's one way to do it, and they keep doing it without any shortcuts. And that's how we get better at it. I also learned the value of minimally invasive surgery for lots of discitis cases. Here, when we do just a CT guided biopsy, we don't get that kind of yield. And I learned that doing a minimally invasive decompression also relieves pain dramatically better than just doing a CT guided biopsy. So you can see this patient with a thoracic epidural collection. You did a CT guide, minimally invasive. This thing drained the abscess, got a tissue for diagnosis, relieved his pain and his neurological dysfunction. But obviously, minimally invasive surgeries won't work for these. Like how we see TB extensively, they see a lot of pyogenic infections, either due to HIV or IV drug abuse. And then we routinely did these big constructs. One might feel that this might be an overkill, but this is how they do it. Obviously, it's different in different places. Here you can see that this guy's got a lumbar significant osteomyelitis, and we did a all posterior surgery for him in this fashion. And this patient had a transected cord for over 20 years, but was draining pus from the wound. And nothing really closed it. The plastic surgeon said that unless you correct this deformity, we can't approximate that sinus. They tried multiple flaps, everything failed. And then finally, we fused this patient. You can see we couldn't get in a cage, so we put 4 TLIF cages at that single level. And this was a very different way of seeing things. We see a problem as spine surgeons or as neurosurgeons. Someone else might see the same problem completely differently. And the key is to be really open to these experiences, and with an open mind, see what the other person has to offer. Because I've learned that there are many ways to skin a cat. We learned several minimally invasive techniques for adjacent segment disease. Here you see this patient has had an L3 to S1 fusion before, and now developed an L2-3 adjacent segment disease. And instead of opening the entire back again, we did a lateral interbody fusion in L2-3 and then put in facet screws at that level. I had never seen or learned how to put in lumbar facet screws. And this was a nice, neat little thing with a small 2 centimeter incision. You can correct significant adjacent level disease. And whatever we did, we had the time to write about it and publish it. Also, there are very strong proponents over there of anterior lumbar interbody fusions. And sometimes they do it standalone, and sometimes they do it along with posterior construct. So it's it's like doing an ACDF. It's just exactly equivalent to an ACDF. They get along an access surgeon, and they have retractors in which you can do it minimally invasively with a 4 centimeter incision para-umbilical. So this is a patient in whom had an L4-5 fusion, but had pseudoarthrosis at L5-S1, and then went ahead and removed the L4-5 screws and did a ACDF, did a ALIF from the front. We also did a lot of minimally invasive sacropelvic fusions, in patients who need extension of their fusion down into the pelvis for pseudoarthrosis. And especially these techniques are really good to learn because most of their patients are like this. So imagining reopening these patients who've had 2 or 3 surgeries with the kind of scarring, fibrosis, these minimally invasive surgeries where you can address the problem from a separate incision or from a smaller incision elsewhere really help learning. So, I went there with a lot of fixed ideas, and I didn't leave anything to chance. I was open to, changing what I had learned and how to incorporate it in my practice. The other thing I learned is that we see low back pain so commonly, but there everybody is a smoker. And the incidence of peripheral arterial disease is so high that this lady, I saw in India a couple of years after I came back, and she had classical left L5 pain with typical neurogenic claudication. She couldn't walk for more than 5 minutes. She had a laminectomy in her hometown, but she said that she didn't have any relief. And she was insistent on me that I redo the operation. There must be, someone told her there must be some scarring. Someone told her it must be fibrosis. So, but the MRI is absolutely clean. There are not even footprints of the previous surgeon, but she had very, very typical radicular kind of pain. And, you know, the textbooks don't differentiate. While we know the difference between vascular and neurogenic claudication, patients really don't. And when we palpated her dorsalis pedis, she didn't have any pulse. We got a CT angio, and you can see there's a large block at the aortofemoral junction, which we stented, and she was completely pain-free the next day after the procedure. So I make it a point to palpate the foot in every single case of lumbar radiculopathy. In a busy practice, we may skip doing it, but you may get the correct diagnosis once in a lifetime. So what I learned in conclusion is that you have to, you know, identify deficiencies in your techniques through feedbacks from patients and through an audit of your outcome. They do very thorough audits of their outcomes, and we seek solutions for these deficiencies. We have so many people now to discuss solutions with these forums available. We can openly discuss solutions with a mentor and then correct whatever you've done wrongly. The effort is more mental than physical. And then obviously you have a lot of extracurricular activities over there, and that's the beauty, you know, the sharing with time and space with your mentors outside of work is very, very rewarding and encouraging. And then we had, and this is with Dr. Edward Benzel, who is a renowned pioneer in spine surgery. All these famous people come to give lectures at various universities, and you have the opportunity to travel across the country to be able to speak, give talks, present your work, as well as listen to these people. We had the chance to look at the Globus headquarters, and where we were taught how these patents are made, how instruments are actually designed, what is the process that goes into the making of implants. At that time, the Globus robot was just launching, so we had a chance to work with it in the cadaver lab. And then you see a lot of fancy patients as well, some of them who decide to tattoo their implants on their body just as a memory of their operation. And then you get to meet people from various states and this was the AO Spine forum where we had a meeting in Banff, and this is Christopher Shaffrey, who we spent some time with. And sometimes your work is recognized and acknowledged, and we were able to get this paper on the cover of Journal of Neurosurgery. The spine section is an interesting case, but I won't go into those details. So I'm going to end with a case that my mentor, actually, this was a lady who had a 2-level problem, significant L4-5, L5-S1 stenosis. And she was seen in Rush University, and she didn't have insurance. She was an African-American lady, and they told her that the surgery is going to cost you $350,000 US. And she said she can't afford it. They said, we've just trained someone who's moved to India. If you can go there and do it, and then it might be cheaper. So she actually flew down to India from Chicago. We did a minimally invasive 2-level TLIF. You can see these 2 incisions. Did a really nice operation. You could see how she walked before surgery, and this is her after the operation, completely almost unrecognizable. Looks like 2 different people. And she went home business class with the cost of surgery was less than $10,000. So she saved about $340,000 thanks to my fellowship mentors. So, you know, going to these places, you learn that getting better is possible. It doesn't take genius. It just takes diligence. It takes moral clarity, and it takes ingenuity. And above all, it just takes a willingness to try. Thank you very much for listening to this and for allowing me to be a part of your program. I'm really appreciative of it.
Thank you, Mazda. Wonderful presentation, and you put your heart into it. That's what we can see. That you really showed what, and a lot of youngsters are watching. Huge viewers are from all over the world are watching this program today, and I'm sure a lot of points. Anything, Samir or Shardul, you want to ask to Mazda?
Yeah, I just wanted to appreciate. It's a very good presentation he's made. I just went to the SRS Cup last week and met most of the guys that he has just mentioned. So what I feel is now we have this ASSI fellowship as well. I have one of the ASSI fellow. So to a large extent, we are reaching to the level of differentiation into cervical and tumor. So we have this traveling fellowship where we can go to mentors, where we can have exposure to all these types of surgeries. But what I was there at HSS a couple of years ago. So what Dr. Todd Albert told me was that you should always learn the techniques when you go to a fellowship, but not the indications, because the indications are based on the system and the practice where you do it and not on the techniques where you do it.
Perfect. Very well said, Shardul. And I think we move on to the next agenda of debates. We have two speakers for this, and basically it's always ongoing. I have met a couple of people. They feel that I always prefer to do simple decompression. Zyada problem nahi hota hai. Decompression karo, no problem. Baad mein kuch, no infection, no adjacent segment, all these things. And I met some people. They told, fix it and forget it. Your back pain and leg pain significantly better, and you'll have really very good outcome of the patient. And this is always a debate. And for this, we have two renowned spine surgeons from India. First is Dr. Mihir Bapat, which we all know is a stalwart from Mumbai and practicing at Nanavati. And the person who is against Mihir is Dr. Kiran Lingutla, who will be debating for fusion. Dr. Kiran Lingutla is trained in England and is practicing at Yashoda Hospitals, Hyderabad. I would like to throw the ball into the court. Mihir, whether you would like to start first or yeah.
Shailesh, I would like to tell you a genuine problem. I can't see screen sharing on my computer. Now somebody will have to share the screen for me.
Okay. Samir,
let Dr. Lingutla start first.
Okay, we can do that. In the meantime, we can just. Yeah. I will ask Samir to contact with you, and Samir will share the screen. Samir Ruparil, can you do that?
Only me? Yes, sir. Yes, sir.
No. Samir Ruparil.
Yes, sir. I will just call, sir.
Yeah, please coordinate with Dr. Mihir, sir, and we will ask Kiran to share his presentation first.
Yes.
And followed by the second interesting debate of Dr. Samir Dalvi, who is again one of the renowned stalwart from Mumbai versus Dr. Umesh Srikanta, and that is again on posterior surgery in degenerative scoliosis, degenerative spine versus OLIF. Hello.
Yeah, I go first, right?
Yeah.
Okay. Hello.
Yeah, Kiran will be starting. Mazda, I think some cross connection. Yeah, Kiran, please share.
Okay, can you see mine? Yeah. Okay. Good evening, everyone. Thank you, Shailesh and Sancheti Hospital for the opportunity, learning opportunity, I would say. And
have you done a recent MRI?
I think someone is still kindly mute all the speakers. Something.
Yeah, we might. Is it possible? Is it possible for you to come and see me?
Yeah, I think some technical. Yes, Kiran, over to you, please.
Yeah, as I was saying, good evening, everyone, and thanks, Shailesh and Sancheti Hospital, and very good evening to all the seniors and colleagues as well. I'm Kiran. I'm practicing in Yashoda Hospital, Hyderabad. So my topic today was for the debate. It's lumbar decompression and fusion together. Okay. So I was just thinking how to go about with this presentation to make it a bit more interesting. So we have divided into a few episodes of sorts. So first one will be the degenerative cascade by Kothari and Wells. That's winter is coming. If we can get the theme of the presentation. Next, I'm going to mainly talk about the degenerative spondylolisthesis. That's a King's Road. And next one is Mr. Lord Snow. So one of the first case of degen spondy case. And then the wolf and the lion. That is a failed back syndrome. And finally, the golden crown, decompression and fusion. Okay, how do we get to that stage? So as everyone, pardon me if this is a bit basic, the Kothari-Wells cascade is the degenerative cascade. As we all know, what does this cascade say? The degenerative process involves both the facet joints, the disc as well at the same time. Because when there is a disc degeneration, like a circumferential tear, and there is a synovial reaction at the back, so both the anterior and posterior parts are degenerating together. First, there is an initial dysfunction, there is instability, and there is auto-stabilization after some stage. But the patient usually presents in one of these stages for treatment. This is a disc degeneration grading schemes. The first one is an MRI, how a pristine disc looks like in the first slide, and the anatomical specimen. And the third one is a discogram. How do you see that? So there are sequential stages, how the disc degenerates from a pristine disc to a completely degenerate disc as well. So I picked up the topic of degenerative spondylolisthesis, that is the King's Road. When you look at this thing, the King's Road, actually, this is the way for the spinal canal, where your spinal cord traverses. And you have this overgrown trees and everything. That's the facet arthropathy and ligamentum flavum hypertrophy. This all contribute, and also the disc bulges. Everything contributes and causes compression of the spinal canal. So it usually follows a degenerative cascade, as I was mentioning earlier. So there is a facet and flavum hypertrophy, segmental instability, degenerate disc disease, and neural stretch usually causes these symptoms. There is usually conflicting literature as to which is the optimal surgical procedure for these kind of patients. So what are the objectives of a surgical decompression? A is to relieve neural impingement, must not destabilize the spine further. You have to minimize complications and reduce the risk of revision surgery. And you should obviously have an improved functional outcome and end up with a happy patient at the end. So the surgical dichotomy is adequate decompression requires satisfactory bone and soft tissue clearance, thereby increasing risk of instability when there is increased resection. Therefore, good decompression potentially destabilizes the spine more. Well, I would say that definitely decompression works, but usually initially, I've been through literature from the past and the present as well. Long-term evaluation of decompressive surgery for degenerative lumbar stenosis. There is high incidence of initial success, but 27% failure at 5 years. Higher surgical failure rate was seen, especially the spondylolisthetic variants. To forestall recurrence, you always should consider stabilization. So what is the short-term and the long-term haul? So degenerative spondylolisthesis with spinal stenosis, a long-term study. 100, it is in prospective RCT, 100% follow-up on a small cohort of patient of 47. Statistically significant improvement in clinical outcome in the solid fusion group, 86% versus 56% at 7 years. So we come to the cases as well now. So the first one of the Lord Snow one, it's a degenerative spondy case. She's a 48-year-old homemaker with chronic low back pain and neurogenic claudication in both her lower limbs, failed non-operative treatment for up to 12 months. So this was her MRI. Obviously, it's a degenerate slip at 5'1", causing bilateral foraminal stenosis as well, contributing to her symptoms. And that's a CT scan. We have at that level, the facets, there is gross hypertrophy and there is significant narrowing of the canal as well. So what did I do? These are all my cases. I did, a kind of spondy reduction and did a TLIF at that level. And she was quite good after the surgery and was mobilizing independently thereafter. So what is the wolf on the lion? This is a case, it's a failed back syndrome case. It is a 70-year-old lady. This is actually a quite recent one, high BMI, hypertensive, and she had the stenotic symptoms as well. She had previous lumbar decompression surgery about 4 years ago for 4-5 lumbar canal stenosis with no relief of symptoms. When she came to me, her clinical and radiological examination was done, and it was picked up she had a wrong level with persistent L4-5 stenotic symptoms. So a revision spine surgery was offered to her. So this was the radiograph she came in with. She had a listhesis at L4-5. If you can, this is a poor quality X-ray, I didn't have to repeat it. But I got the MR and the CT done. The first of the MR shows actually the surgery was done at 3-4 level, where you can see this slide shows 3-4 laminectomy. And at L4-5, she had persistent 4-5 canal stenosis. You can see the multifidus completely replaced by fatty degeneration of multifidus as well after so many years. So that's the CT scan. So definitely she had a 3-4 laminectomy. And at 4-5, there's significant facet joint arthrosis with spondylolisthesis and a vacuum disc as well. So after having a chat with her and explaining all what has happened, put things in perspective, and I've offered her surgery. And this was because she had a previous decompression. I went ahead and did a posterolateral fusion at 3-4-5 and 4-5 interbody fusion as well. So pedicle screw stabilization constructs, they actually increase fusion rates. They have improved functional outcome, reduce the subsequent slip occurrence and progression. And it also gives us the advantage of reduction and sagittal realignment, which improves functional outcome, reduces back and leg pain, and longevity of the result is achieved in this kind of procedures. So this is the most recent evidence I could find from literature search in paper from 2022 from Neeraj, Bali. Decompression with fusion had a greater efficiency than decompression alone. This is, mind you, study for spondylolisthesis. It's a systematic review, meta-analysis, and meta-regression study as well, with a large cohort of patients, up to 4,000 patients from 13 studies were picked up. So finally, the golden crown. I would obviously put my things against, go for decompression fusion. Thank you very much. And I thank everyone for the patient listening.
Thank you, Kiran, for the wonderful defense for the fusion. It's not a very easy task, and we really need that, that I really want to talk, because I believe in fusion. And let's hear from Dr. Mihir, who will be talking about only decompression in his main cases. Over to you, Mihir.
I think, Shailesh, do you really want me to talk? Because Kiran doesn't have a case to present a fusion. Now, let me tell you that I'm an aggressive fuser, but see this and you will believe that how wrong we are. Okay, yeah. So I think I'm not.
संभाल के सर.
क्यों?
सर आप पहले सिक्सर मत मारो सर, जरा आराम से.
नहीं. You look at the next slide. Okay. Next slide. So the fusion decisions are true. नहीं आगे मत जा यार, मुझे बात तो करने दे. हाँ. तो fusion decisions are true only when there is a genuine instability.
Can you enlarge it, Samir?
Yeah, please do. Everyone needs to see this.
Yeah, thanks.
Yeah, so the fusion decisions are true only when there is a genuine instability. Otherwise, they are just childish. they are naive, and they are cruel, in that order. So let me go on to each of these titles and prove my case. Now let us go to the childish. Next slide, please. So patient has significant back pain. What do you mean by significant back pain? Everybody has back pain. Is 90% of the patient's activity reduced because of back pain, or the patient can still do his daily activities with back pain? So every patient deserves a fusion. That is the criteria. So that is meta-analysis of all patients across the globe. Sorry, doesn't work. So black disc, stable lytic listhesis, and degenerative discs fall into this category. Next slide, please. Excellent case. So this is a case with my own follow-up of 15 years, where a large black disc has been managed by simple laminectomy. Now, the offerers of MIS can argue with this. I give it to them that you can do it MIS this time, but laminectomy remains stable even in a borderline listhesis for years and years. So the metaverse of analysis doesn't work here. Next. Naive. What do you mean by naive? Large disc, there are higher chance of recurrences. Facet cyst, it is instability, even in the presence of a stable listhesis. Fusion, adjacent to a degenerativeness. You have noticed a degenerative disc adjacent to it, but you want to fuse that segment because you are a minimally invasive surgeon. Next. So this patient is our own follow-up of 8 years. He's a pilot. A fusion would have ended his career. Now, this is a simple microscopic discectomy which has lasted the test of time for 8 years. And there is a degenerative disc next to it. Does not warrant a fusion. Thank you very much, sir. Next slide. Now, this patient, very well fused, fantastic. But notice the cage sinking. Thank you very much. So if you recall Kiran's paper where he had showed 86% at good results, niche ka line which he did not highlight was there was higher blood loss, higher complication rates, higher hospital stays, which was the next line which was not highlighted in his paper. Next slide, please. This is a case of a facet effusion with a borderline stenosis, very well fused, minimally invasive fused, fantastic results. Next slide, please. Cage sinking. Patient came back with terrible back pain. A second cage was put on the side because they could not retrieve the cage. Next slide, please. Patient landed up with bad infections, Klebsiella pneumoniae, fixation extended by me, and the patient now is stuck to me, unfortunately. Thank you very much. Next slide, please. So this is a right facet cyst with facet effusion, borderline instability, managed only with cystectomy, which stood the test of time for 4 years. No recurrence, no back pain, no leg pain. Next slide, please. This is another case of facet instability with a borderline stable listhesis, again managed with a facet cyst excision, 5 years follow-up, no recurrence, no progression of listhesis, stable results. Next slide, please. Cruel. So when you have an elderly patient with a multiple level pathology, you have this temptation of correcting and giving the patient a better quality of life. But beware, these are the worst cases to handle and they will give you the worst kind of nightmares. Next. So this is a patient with a so-called multi-level stenosis, a stable decompression which has lasted 8 years. I've pulled out these cases from my own stock so that I can show it to you for long-term results. Stable, no progression of any instability after a laminectomy. Next. This is a case again of a multi-level stenosis, mild degenerative scoliosis at the end of 8 years, but no leg symptoms, no significant back pain. Yes, back pain is there, but no significant back pain. Next slide, please. So this is another case of a degenerative listhesis. Dr. Bhojraj has been saying this for years. So this has been debated and he has proven that these results withstand the test of time and these patients remain symptom-free for years and years endlessly. Next slide, please. Now, this is an excellent case of an excellent fusion. Nobody can doubt the position of the cage, the position of the implants. Look what has happened. This is not in your hands, sir. Fusions fail, and they fail very miserably. Next slide, please. Excellent fusion done, minimally invasive, superior end plate fracture, a bigger surgery. So thanks to Mazda Turel, he started out with an L4-5 pliff, ended up from C2 to S1. Thank you very much. Not to be done. Next slide, please. So this is a case of an adjacent segment instability which was neglected because of a borderline degeneration, worsened over a period of time and had to be extended. And again, you have to revise with implants. That is the problem. Next slide, please. Thank you. I think I have rested my case. Am I audible enough here?
Yes. Thank you, sir.
Is everyone stunned? Or
no,
they still want to debate?
Yeah, I think everybody is still coming to terms that are we really doing the right things in most of the patients which we fuse?
Yeah, one thing I would like to point out what Mayur said. It is the most of the words he used most commonly was stable throughout his presentation, and most of his X-rays. You have an L5 that is parallel to the floor. You have a stable spine, a degenerative problem. So I would agree with him. Decompression alone would work in that cohort of patients without major instability. Another important thing was with regards to fusion. I'm not a man with a hammer. Everything looks like a nail to hammer on. So you have to pick and choose each and every case in its own merit. As I said, an unstable slip definitely would warrant decompression and a stable fixation. But this is for the juniors who are probably watching this. There is role for both of them, but you have to pick and choose your choice of patient. Why does the surgery fail? Surgery fails because of wrong choice of a technique and a wrong choice of implant sometimes. And the cages that have backed out are mainly PEEK. I don't use PEEK, but because of obvious reasons. There are two schools of thoughts who use PEEK and who just stick with titanium cages. All the cases which have failed are the PEEK cages, which I could see there. So I would say, if it is unstable, definitely fuse it and try and use more of a titanium cage, in my opinion. That's what I would have thought.
My question may be answered by Kiran as well as Mihir sir. Usually, what mainly bothers me during a particular scenario and where I have confused is having a grade 2 list at a particular level. Suppose a 2 level are stenosis, L3, 4 and 4, 5 both are stenosis, but L4, 5 is grade 2 and above is stable. So whether to only decompress that above level or to add another fusion and what kind of fusion, I want both of them to answer this.
See, the above one you said is a stable one, and the lower one is the unstable one. You could pick the best of both. You can do an uninstrumented kind of decompression at the top, and do a interbody fusion at the bottom, because that's in your index case. There are some cases where the patient comes to you after, like my second case which I mentioned, after initial surgery. So we are forced to kind of do a stabilization on the level above us. But these are few and far in between, I would have thought.
I think, thank you, Kiran, thank you, Mihir, and it was a wonderful defense from both the sides, and there is no clear-cut winner. This was Hrithik Roshan from Mumbai versus Vijay Devarkonda from Andhra Pradesh, and it was really interesting to see. And in view of time, we will have to proceed with the next, and I think it's a case.
Yeah, before we end this debate, can I just say
yes, a few? Of course, yes.
A lovely debate. Both pointed their points very well. But just for the audience who's listening, debates are meant for you to fiercely defend your point of view, obviously. But there are 2 points I want to make. Number one, in spine, you have to individualize treatment to a particular situation. The situation is the patient, the symptoms, the imaging, your skills and your experience. So one size doesn't fit all. You can't obviously say you fuse all or don't fuse all. That's one. This is for the juniors. This is not for the panel. The second very important thing, this is also for the juniors and also for the seniors. I have come to the conclusion after 22 years of practice that you cannot win in spine. You cannot win. So you just do one thing to solve a problem at a particular time. This means if you only decompress, few years later you may have to fuse. And if you fuse, then few years later you may get an adjacent level. So you can only solve the patient's problem for a given point of time. I don't think you can solve the patient's problem forever and ever. There is no such thing as happily ever after in spine. So with this thought, we'll end this topic and go ahead to the next one.
Perfect. Very well summarized, Samir sir. And the next hot debate again is that we are seeing nowadays a lot of new technologies coming up and how we are going about. And that's a debate of lumbar scoliosis, lumbar degenerative spine, and how we deal with it. Dr. Umesh Srikanta is a neurosurgeon from Bangalore, and he's doing a lot of advanced stuff, and he's known for OLIFs. I would like Umesh to start the shot, and Dr. Samir Dalvi, as we all know, one of the great stalwarts from Mumbai for more than 2 decades, 3 decades. Dr. Dalvi is practicing. He'll be talking about posterior surgery in this scenario. So over to you, Umesh.
Yeah, thank you so much, Shailesh, and hello everyone. Hi, Dr. Samir. So I've been given the task of defending OLIF, which we have been practicing for the last 6 to 7 years, and to see whether truly is it better than MIS TLIF and the results that the literature claims, or we claim in several of our talks. Is it worthwhile to pursue OLIF as compared to an MIS TLIF? So as we know, there are several ways of achieving an interbody fusion. MIS TLIF achieves it from a posterior route. You do a facetectomy, interbody work, and then you do a percutaneous fixation. In an OLIF, it's an outside the canal approach. You do it from a retroperitoneal trajectory. It is also called as an anterior to the psoas approach. And it is quite different from what we were doing earlier when we started off in 2014, 2015. That is an XLIF that was a trans-psoas approach, which was associated with significant morbidity, and some of which has actually, put a dampening effect on the lateral retroperitoneal approaches. So that is the difference between trans-psoas and an anterior psoas approach. Now, as you see, so when we moved from an open TLIF to MIS TLIF, we all know the complications that can be associated with an open TLIF. When we moved to MIS TLIF, see, the amount of work that we were doing in the peridural area inside the canal was almost the same as in an open TLIF. The chance of dural injury, the chance of nerve root injury, post-op epidural adhesions, risk of post-operative neuritis, dysesthesia, so almost remain the same if you are doing an adequate job in an MIS TLIF. And the only complication, or the only thing that we have reduced from an open TLIF is a paraspinal muscle injury. It has given us significant benefits, but with OLIF, we are completely coming outside the canal. And in selected cases, whenever OLIF is indicated, it can achieve the same objective as we are doing it for an MIS TLIF. That is, it can achieve a good indirect decompression. It can reduce a spondylolisthesis. It can correct a coronal imbalance, and all this without, as I'm going to show some examples, without entering the canal. And and that there are several advantages. That there is no paraspinal muscle injury. It's an outside the canal. There is no risk of epidural adhesions, no risk of nerve root handling, no radicalitis, no chance of nerve root injuries, post-op dysesthesia. Everything has gone. And only, of course, OLIF comes with its own set of different complications, but it is not very significant. And also the OLIF, as we know, that the apophyseal ring of the vertebral body is in the peripheral area, and that is the strongest area where we can put in a cage, and a cage that spans the apophyseal ring actually is much more stronger, which is helpful in osteoporosis. And theoretically earlier it was presumed that at least it causes a significantly lesser incidence of subsidence, which is again common in cage that is placed centrally in the cancellous portion. And it has been shown in several biomechanical studies that spanning the end plates increases the load failure by 40% in an intact end plate, and even in a decorticated end plate, it increases by around 30%. There are several other advantages of an OLIF. OLIF is the only approach that we do for an interbody fusion that virtually preserves all the natural structures of the spine. We enter the disc through a completely virgin area. The facets are preserved, the facet capsules are preserved, the posterior spinous process, posterior interspinous, supraspinous ligament complex, ligamentum flavum, entire posterior annulus is preserved, ALL is preserved, the PLL is also preserved. So all the ligaments are preserved, and virtually the OLIF achieves what we need to achieve by preserving all natural structures of the spine. And we know that by achieving uniform interbody distraction, it kind of it kind of achieves that reduction in the listhesis by effect of ligamentotaxis, and in cases of lumbar canal stenosis, whenever a fusion is required, so it just increases the disc space and reduces the bulging disc or a buccal ligament of flavum to restore the canal dimensions that is sufficient to restore. And we know that the amount of interbody distraction that we can achieve, indirect decompression, which will result in indirect decompression, is significantly much more in OLIF as compared to any posterior approach. And it has been shown that this kind of a result in a spondylolisthesis can be achieved even without entering the canal, virtually complete restoration of spinal canal dimensions without even entering the canal or touching any of those nerve roots or this one. And even in presumed bone-on-bone kind of listhesis also, we can actually do a significant amount of distraction to achieve that. And especially in these kind of cases where there is only a foraminal stenosis with foraminal symptoms, where it's actually not ideal or not fair to enter the canal and remove the facets which are not involved in the pathology at all. And these things also can be achieved, as you can see above and below in the pre-op and post-op MRI images. The entire canal dimensions as well as foraminal dimensions can be restored by just doing an OLIF approach without entering the canal. And this has been shown in several studies that OLIF achieves a significant amount of increase in the disc height or a foraminal height and foraminal area, even increase in the dural sac dimension. And a comparative study has shown that between MIS TLIF as well as OLIF lateral approaches have shown that the increase in the canal dimensions as well as the foraminal and disc height is significantly more in OLIF as compared to. So this is another recent study that has come out, which has again shown that the estimated blood loss, operative time, length of hospital stay, and post-operative serum creatinine kinase level are again significantly better with OLIF. And this is not just a single study or just one case that I'm going to show. There are several different literature studies that are available which show that OLIF is better. And especially when we come to L5S1. So we know that L5S1 is a wedge-shaped vertebrae, and in these kind of unstable listhesis where in MRI it looks perfectly aligned, whereas the patient standing flexion X-ray is showing a significant instability, translational mobility. And in those cases, we know that these with a posterior approach, we don't have the armamentarium as of now. We don't have those 12-degree, 15-degree cages that are available with an anterior OLIF approach, which can be used in order to restore or preserve the lordosis, segmental lordosis that is most important at L5S1, especially in the present setting of maintaining the segment sagittal as well as coronal balances. So again, it presumably, again, in these kind of cases where it's completely collapsed, where there is no preoperative lordosis, a significant amount of lordosis restoration can be done with an OLIF for 5-1 approach. And this is the comparison between our own. This is our own MIS TLIF versus an OLIF case, where, of course, in TLIF also we are able to restore the lordosis, but the amount of lordosis that we will be able to restore in an ALIF or an OLIF 5-1 approach is significantly more. And that kind of reduces the adjacent segment tension on the L4-5. In most of the cases, when in MIS TLIF, when we do L5S1, if you are not able to restore adequate lordosis, the L4-5 goes into a wedge shape. And all this can be achieved with a reasonably good complication, profile of OLIF as compared to an XLIF. I understand that XLIF had a significantly higher proportion of, psoas related as well as plexus related issues. But these are completely obviated by OLIF because it is complete and anterior to the anterior to psoas approach. And this has been shown in several multiple studies. And what is more important, ultimately our whole idea is to achieve fusion. And this is a recent, very good study that has come out from a multi-center study, which has shown that in OLIF, at 6 months, 80% of the cases have achieved fusion, whereas in MIS TLIF, it's only around 50%. Whereas, of course, now over a period of time, 12 months and 24 months, OLIF achieves 800%, as well as MIS TLIF achieves around 85%, or sometimes in some case series more than 90%. And when it comes to degenerative scoliosis, I don't think there is a debate between posterior and lateral approaches, because the OLIF creates wonders in restoring coronal balance by putting a uniformly large cage across the interbody space, achieving uniform interbody distraction and restoring sagittal as well as coronal parameters. And all this can be done even without entering the canal. I can show multiple examples. So these are severe degenerative scoliosis, which are quite difficult to be tackled by posterior alone approaches. especially if you want to do it minimally invasive again. So, but with an OLIF with minimally invasive approaches, without entering the canal, without handling any of the nerves, without just by putting cages in 3 levels, you can actually restore the coronal as well as sagittal parameters to a significant degree. And of course, in recurrent cases, this is a patient who had been operated around 4 times previously. Again, in these cases, just by doing OLIF, achieve interbody distraction, significant amount of canal restoration dimensions can be achieved. And I know that I have told several different advantages for OLIF. I'm not going to the details. I'm not going to the indications. But yes, I'm not telling that OLIF is all glory and crown. But it is, there are several restrictions. There are cases where I would like to accede the floor already to Dr. Samir, where OLIF may not be suitable, especially in cases of chronic, that bad degenerative, scoliosis, where there is a facet calcification, where the flexibility of the segment itself is in question, and where we will not be able to achieve the distraction, or even if we achieve it because of the recoil phenomena, there is a significant amount of postoperative cage subsidence, which results in loss of the indirect decompression that we have achieved by distracting that particular disc space. And of course, there are some kind of pathologies that are not suitable for OLIF, where there is a severe central canal stenosis, where there is a superiorticular process osteophyte. Of course, grade 4 spondylolisthesis is not suitable for OLIF. I think that I'll rest my case here. Thank you.
Yeah. Thank you, Umesh. That was a wonderful presentation. Over to Samir sir.
Hello. Is my picture and everything there?
Yeah, you are audible. Perfect.
Okay. Because no, I can't see my image. Okay. So you'll have to spotlight me because you'll have to spotlight me. Anyway, so the point is that why have a debate? I think people should be led to do what they want to do. And I am not going to tell Umesh what to do, because he is a mature guy and he gets good results and he's obviously studied the literature and he's doing something. But what I can say is why I don't do OLIF. So I don't do OLIF. I have not done OLIF, and I've done 2 or 3 OLIF courses. And after each one, I've strengthened my resolve to not do OLIF. So, unfortunately. So I'm going to, the thing is that I have not even kept slides. I'm just going to speak to you. What my question is, the first question is, today, when for all the other spine surgeries, we are trying to, because I love doing anterior surgery. Please don't get me wrong. I was in KEM and I love doing anterior surgery, and I'm very sad that anterior surgery has gone out. I used to love to do anterior scolies. Now we do them all from the back. I used to love to do TB anteriorly. Now we do transpedicular decompression and put cages. So now everything we are doing from the back. After all these years where spine surgery is refined and you can do everything from one approach and not disturb the visceral structures, why are we now going back to doing a double approach? So as I said, I have these 9, there were 10 actually, but I knocked off 1 reasons why I don't do OLIF, and I'm going to go through those. It is unnecessary, it is invasive, it is extensive, it is risky, there's an issue of bone graft, it doesn't really decompress, it is restrictive, it is expensive, and it has a learning curve. So I am going to unshare my thing, because I don't think you need to see pictures. And I don't think I need to show you cases, because it doesn't make any sense. It's just a purely theoretical thing. So the point is that when you are treating these patients with degenerative scoliosis, which we are restricted to, firstly, you must understand that each case is not the same. As I said, every case is different. And if you look at Silva's classification, there are 5 grades of treatment for them. We are looking at the 4th grade, where you require an anterior and posterior fusion and correction of the deformity. Some of them require only decompression, and the last one, 5, requires osteotomy. So those are out. Of these patients, what do you want to do? These patients come to you for compression. They come to you for claudication and neurogenic compression. And there is an element of coronal imbalance, which is not actually their complaint, because we can't really treat back pain with surgery, to be honest. We can treat neurogenic claudication. We need to correct the deformity to an extent, because overall, if you don't correct the deformity, there's a chance of recurrence. So you need to decompress them as a primary priority. You need to realign, and also you need to get a good fusion, because if it doesn't fuse well, then your surgery is going to fail. Now, my first point was unnecessary. Why do I say unnecessary? If you can achieve all these aims with a good clinical result with just one approach and one operation, then the anterior procedure becomes unnecessary. Until and unless somebody proves to me that there is a vast advantage or a vastly superior result by doing a front and back separately, I don't think I can move on to it, especially since those cases which are indicated require a thorough decompression and look at the thing. So like I said, you need to spotlight me. If you don't spotlight me, then we're seeing Sonavani's face. I've purposely, the admin, if you can spotlight my video, I've purposely switched off the thing so people can see my face. Anyway, the second is it's invasive. So the second point is that it is invasive. What do I mean by invasive? Yes, we are operating from the back. And, he showed a beautiful picture. We are not disturbing the ligaments. We are not disturbing the spinous process. We are not disturbing that. But we are going through organs who are like nothing to do with it. I mean, it's like collateral damage. It's like you're killing 20 people because you want to do a small something somewhere. You are going through the coelomic cavity. You're going, you're messing around with the retroperitoneum. You're messing around with the vascular structures, the lymphatics, and all of those structures to do something. You're accepting collateral damage because you don't want to damage the spine. But the spine is the villain. I mean, it deserves to be damaged. It's the one who has created the problem. So we are not damaging the spine by doing the surgery. We are correcting those things which have created the problem. So it's an unnecessarily, you're exposing a new cavity. You're getting a new equation and a new set of issues into something where actually we need to focus our treatment on the spine. It's an extensive surgery because, like I said, we have to do a retroperitoneal exposure. All said and done. If everything goes smoothly, it's beautiful. If something gets wrong, you scream to high heaven, right? That is where the problems start. You have to mess with the source, pull it back. The lumbar plexus is there. The lymphatics are there. We know what all is there. The sympathetic chain is there. When I say risky, the last point, even if you just look at his own slide, if you look at the thing, a vascular complication rate of 1.5% is very high. Because if you're a busy surgeon and you do 100 cases a year, that means you are having like 3 cases of vascular complications over 2 years. I don't think we can really afford to have that kind of vascular complications where you need to get a vascular surgeon or a coelomic surgeon to come and help you and to start running around. Just the other day, we had a clinical meeting where one of the Olive guys presented a case and it takes away half your life. But other than that, there are other issues. The femoral nerve issue has been a little reduced by this Olive as compared to the previous D-lifts, etc. But it is still an issue. You are operating a patient primarily for back pain and you land up the patient getting a femoral nerve palsy or anterior thigh pain, which lasts for 3 to 6 months in the Olive patients. An honest Olive surgeon will tell you that it is a genuine issue. You get sympathetic dysfunction. They have this cold foot on one side for many, many months. So these are things which are unnecessary. Why? This guy has come to your spine and claudication. Why do you want to do this? The next issue is bone graft. Now, as I said, in the 3 things we want to do, one of the things is fusion. And I'm saying why I don't do it. I'm not saying why you shouldn't do it. I find that there is no bone graft. How do I fuse the bloody thing? Abroad, they use, and here also they tell you put DBM and put this and put, bone graft substitutes, and you can even use BMP. Okay, that's all fine. But this is another extra stuff which you're using. And in addition to that, the cost again goes up. It's very easy for the company reps to tell you, oh, you put DBM and put this and put that. But your natural bone graft, when you're doing a posterior decompression, the natural bone graft which you get, which you can put in, you just don't have it because you're doing the anterior surgery. The next point is it doesn't really decompress. Now, what do I mean here? Yes, I am not denying. I've seen the MRIs and the pictures of an indirect decompression. And if there is a moderate decompression, then yes, just doing the reduction or doing the realignment maneuver will decompress. I am not denying it. But like I said, my question is why I don't do it. Those patients who have such borderline symptoms, I don't operate in the first place, or I can't convince them to get operated. Maybe it's wrong. I try to tell them you need surgery, but they don't need surgery. But they do physio and they get totally okay. I call these indications American indications. So these are patients who in the US would get operated. Like, hey, I got a little tingling in my foot. Oh, I got to get it fixed. But our Indian patients, even the patient is paraplegic, they will say, I don't want surgery because I may become paraplegic. So the ones we operate are the ones who are really bad with huge facet, huge ligamentum flavum, who do require a direct decompression. So then it will be really sad if you do this whole procedure for a process of indirect, and then eventually they have to go somewhere else and get a direct decompression done. So that restricts you, which brings me to our next point. It's restrictive And Umesh has very gamely pointed out that there are you can't do all cases. Somebody logged in from 2 devices. Please mute yourself. Okay. So the other thing is that it is restrictive. You can't do all cases. So it's a bit of an excuse. So what happens, my impression, so I'm being a little mean, maybe because I'm not doing it. I find that these people, they have this armamentarium that I can do an OLIF. And then they select, oh, in this I can do OLIF. In this I can do OLIF. It is not that he needs OLIF. In this I can't do OLIF, so I will still do my posterior surgery. So it is restrictive. There are many cases where you can't do it if you honestly select it. And to me also, when I operate, sometimes I tell my fellows, isme OLIF kar sakta tha. That's about it. You can't, it's not like one thing which fits all. It's just a restrictive indication. My 8th point, which is my second last point, is that it's expensive. You cannot deny that it is ridiculously expensive today. An OLIF cage, an imported OLIF cage costs 85,000 bucks. If you're going to put 3 or 4, you do the math. Okay. A TLIF cage, which you can even put an Indian one, costs like 7,000 bucks. An imported one costs 18,000 bucks. I think the cost makes a difference because, as I'm saying, that my talk is not why you should not do OLIF. My talk is why I don't do OLIF. So I find it very difficult to say that I'm going to use 4 cages of 85,000 bucks for the patient. And, it is very expensive. And if you add DBM and all of that to it, again, the cost will go higher. So the cost is exceedingly high. My last point here is the learning curve. So it's true. Now I have been in practice for 20 years plus. I am trained. I've had a lot of training. And now I am like well trained into doing the surgery posteriorly and doing it well. I'm not saying I can't learn OLIF and I can't get trained into it, but I just can't find a reason for it. I'm doing well. I'm getting everything out of it. And this OLIF seems to be just like a new toy which people want to learn. And so I'm just not getting why I should be going through the learning curve, make mistakes and let some of my patients suffer, like get a vascular injury, get this, and oh shit, aisa karna tha. Oh, then learn, oh, this retractor should have been put this way. Oh, that should have been put that way. So maybe those who in their fellowship days are doing 100, 200 OLIFs and then seeing it, maybe they can do it. But I really can't find a reason for me to switch on to it at this stage. And patients also, I don't know how they would accept a front and a back surgery when patients, really very poorly accept any kind of surgery. So therefore, my question is that, is the OLIF really that superior to what we are doing from the posterior that we need to switch on to it and do it given all these drawbacks? And that is the question. And that is the reason why I don't do OLIF. But yes, if somebody else is doing OLIF, all the best to them. I'm not denying that the X-rays look very nice. I'm not denying that probably the clinical results are also good. But I don't think it's better than what we are doing. And I see no reason to switch on to it. Thanks.
I think if you can just give me 1 minute, number one, okay, and unnecessary and all, I can't answer that. But at least, yes, cost-wise, nowadays we have Indian-made OLIF cages, even titanium ones, which are quite reasonable. We don't have to always put in an imported implant.
Umesh,
yes,
hold
sir.
on. I want to ask that question to Samir myself. So you don't ask that question to Samir.
But the debate is with Umesh. It's not with you. Your debate is over, Mir.
No. I'm going to leave the discussion.
See, I'm drinking coffee. You should be drinking beer. Your debate is done.
No, but you're drinking an American coffee, nevertheless. It's not an Indian coffee.
You Indian, hai, Raja?
No.
Okay, sorry.
Okay. So what I'm trying to ask Umesh here is Samir's debate. Do correction of SVAs to the extent which OLIF promises really makes a clinical difference to the patient? And in trying to distract your discs, in particularly Indian patients who are inherently osteoporotic, do you really manage to correct the SVA so much? So these are the two issues.
Not in all patients, sir. Not in all patients. Nowadays the concept has changed. Means OLIF started, when it started, it was like a perfect, aiming to achieve that perfect SVA scores. That PILL imbalance, all those things. But nowadays, I think the concept has moved on to what is something we call as age optimal balance, in the sense like the balance should be optimal to that person's age and the activity level. So which is ideal. And I also mentioned in my this one also that, in the presence of a significant facetal arthrosis or in the presence of chronic ALL calcification, chronic ALL shortening, if we don't do an anterior release or a posterior release and we just distract this, over a period of time, this recoil is going to happen again, and the cage is going to subside, and whatever effect we have achieved of indirect decompression during the surgery, during the distraction, is anyways lost in the post-operative period. So OLIF is not for every case. It's not for all the cases. But in mobile segments, even in severe degenerative scoliosis, it can achieve a reasonably good coronal. Even in the X-ray I showed, it was not like completely straight spine. It was still, there is some amount of imbalance that is there, but at least a reasonable amount of balance can be achieved. But the whole good thing is that when we are doing multi-level, if we are doing a posterior approach, for example, if I do an MIS TLIF for the same case, if we have to do everything is going to be multiplied the number of times the level is there. So, but in an OLIF, once you get into the retroperitoneal space, number one, it's not a cavity in the sense we are not transgressing any organs. So it's a completely retroperitoneal fat. We are just going through the retroperitoneal fat. All the peritoneal structures are going, or retroperitoneal structures are moving anterior. So this is not like we are transgressing any organ. And through a retroperitoneal approach, once we go on to one disc space, you can just jump and the anterior border of psoas from one space to the other space, it's right next. So each level is hardly going to take another 30-40 minutes extra. So that is the advantage, and that is the comfort that OLIF gives. And the vascular injury, that 1.9% in that series was including L5S1 series. And we all know in L5S1, 1.9 is very, very low. In L5S1, if we include ALIF and OLIF 5.1, the incidence of vascular injuries have been reported as high as 8%. But I agree that that is high. It may not be suitable, or it may not be there for all persons. And many times, even for ALIF, we always call a vascular surgeon. We don't do the access by ourselves. So, of course, there are limitations. There is a learning curve. But I feel that there are benefits that OLIF or 5S1 ALIF can offer. Because of non-handling of the neural structures, because of complete preservation of the posterior elements, and probably a better post-operative extensor muscle function.
So, Umesh, in your experience, do you feel really, now if OLIF has been there for quite some years now, do you feel that the procedure is catching on, or the procedure is still remaining restricted to a few people who want to do it?
So it is catching on in terms of the number of people adopting it, but compared to the pathologies that it is being adopted to, I think we are becoming restrictive. So, for example, earlier I would have done OLIF even if the facet was very arthrosed or anything like that. But nowadays we have a strict selection criteria. All these chronic cases, when there is a doubt, patients with rest symptoms, if the patient has a rest symptom, it's unlikely that it's going to get corrected by just an indirect decompression. And patients with even severe stenosis who don't have rest symptoms, who have just dynamic symptoms, who just develop these dynamic symptoms on mobility, and they also do perfectly well with OLIF. And I have examples of post-operative MRIs where the canals is still significantly constrictive, is significantly closed, but the patients do not complain of the symptoms. And again, follow-up studies in this case have shown that once we stabilize that segment, the ligamentum flavum as well as the kind of regret, and there is a significant difference between an immediate post-operative MRI versus an MRI done at 2-year follow-up, where the canal has opened up further because of the stabilization. But yes, the number of our selection criteria for OLIF has become quite strict. And even though our original idea or original thought process that putting a large cage is going to give more stability and going to prevent subsidence is again not, because OLIF subsidence rates are quite high. And we have to be very careful in end plate preparation, especially in osteoporotic patients where the subsidence rate are quite high in these patients. So it's not like OLIF is an answer for everything, but appropriately selected cases, I think it gives wonderful results.
I think it was
I know. Wait, Shailesh.
Yeah.
Where is Samir here?
I am quiet when you are speaking. I can't afford to speak only.
No. I just want to ask you a very, very simple, naive. I'm a great fan of this word. I don't know why. A simple question is that the implants are free for you. The vascular surgeon is free for you. The decision between a degenerative scoliosis for you then would be an OLIF with the posterior screw, or still an open degenerative scoliosis correction?
I mean, if everything is free, Why? I would still not do an OLIF.
You still don't believe it?
No. This is my cost is not my only reason. Cost was one of the reasons. Like you pointed out, we have either super rich patients or super poor patients who come under charity schemes where the cost doesn't play any role. It is not only the cost. I genuinely believe that what we are doing is fine. I mean, there may be some cases where I love it. I love their X-rays. I love the whole thing. I'm not denying that. But I would still. So I would say, let's do OLIF. Let's do OLIF. Let's just do what we always do.
Perfect. So I think Shailesh, me and Samir are getting old. Umesh is still young. His hair looks black.
I agree, and I think
it is very important. No. I just want to again clarify. I want to again put it is very important that these surgeries are done. It's very important that the learning curve goes through. And in the long run, if this works and the future fellows are trained in that way to do it right from the beginning, and the patients are also trained that if you have this surgery, you have one anterior and one posterior surgery. Fair enough. If science progresses, it's fine. Like I said, my debate topic was why I don't do OLIF. It was not why.
I think, Dr. Dalvi, completely agree. And this is a message for all that this is not that this particular technique is right or wrong. How I give best result to my patient. And this is what was the question. And Dr. Dalvi, with his vast experience, Dr. Umesh, with his vast experience, they are doing a good work. And it is a case-based selection. We have to select a patient. We have to select. We should know all the things which are coming up, and we don't know how the science will go tomorrow. So this is not one person against the other one, but this is again talking about our philosophy, how I prefer to do my particular scenario in this particular patient. So this was a wonderful debate of Mumbai Indians, Sachin Tendulkar versus the CSK's MS Dhoni, and there is no clear-cut winner. It was a tie, and I must compliment both of you for a wonderful show.
All challenges Bangalore's Virat Kohli, not CSK.
Dave sir wanted to talk.
So it is Bangalore's Virat Kohli, and it was no one is a clear-cut.
Dave sir wanted to.
Yeah, I think if I may add my experience into it.
Yes, sir.
I think as you already have narrated that the case-based, you have to have the plan tailor-made, but at the same time, the correction that you get with OLIF is superb. I think the back pain incidence is much, much less. So if Samir was asked that, which one would you select for the technology, for everything, then probably my answer would be, I would select OLIF, because everything falls in the right place at the right time if a given deformity case degens coli. And I'm sure there are surgeons now who do 3-level OLIF as well in Gujarat itself. And, they advocate the same surgery too.
So I think what works best in your hand is your answer for the best outcome of your patient. And in view of time, I would like to thank both Dr. Samir Dalvi for a wonderful presentation and Dr. Umesh Srikanta for a beautiful presentation. And we'll move on to the next topic, how to run a spine center and challenges we face. And none other than Dr. Bharat Dave, who has vast experience of around 3 decades and running a big show in Gujarat's Ahmedabad city. And they have a huge setup along with all the latest technology and a very big team. Dr. Ajay Krishnan, as we all know, is a working hand. And he's also a big stellar spine surgeon with Dr. Dave's team and others. So I would like to invite Dr. Dave for learning from your experiences for all the viewers and us to know about it. Over to you, Dave, sir.
I think it's something which is going to be played from the record.
Yeah.
Or shall I?
Yeah.
Am I allowed to talk live?
If you want to share, you can share, sir, directly. That
if you can allow me to share.
Yeah.
So I'll stop sharing.
Yeah. Can you stop sharing and I can?
Yes.
Yes.
Where do I go now?
Just share screen.
Share screen.
I'm not able to get the share screen view.
It'll be bottom green button. So.
Setting. Do I go into setting? No.
No, it should be there exactly on the bottom line. So share screen.
No, not getting it. It's not there. It's chat, setting, reaction, and participants.
Oh, okay. I can share for you, sir, if you want.
If you can share for me, or I have my presentation on, or
So no, there is a green button with an arrow up which shows that share screen.
It's not there. I know it's not there.
Okay, okay.
Okay. Make him a part. Sorry, you have to upgrade him to something. What is that called? I don't know.
Yeah, some upgrade you think? I think it was.
I think Ashok
make him host. Make him host.
Yeah, make him a host. Yeah, that's the correct. Yeah.
Ashok.
Or else play. Let's not waste time.
Okay, so I can share.
Yeah, please share.
Yes.
Sir has already given a recording also, so we will just scroll through.
The video is seen?
Yeah.
Yeah, video is seen. Yeah, sure.
Greetings from Bharat Ardave. Thanks for giving me this opportunity to share my experience related to the challenges to run the spine center. I have identified challenges and I have tried to answer how to circumvent those challenges and particularly how we do it at Stavia. This talk is purely on experience base at Stavia, and I have taken the views of all my consultants and all my colleagues, those who are working at Stavia Spine Hospital. Is medical profession an industry or a business? Well, I think healthcare model is an industry. It is comparable with the Tata as an industry. Let's earn and invest and cherish and do some charity work as and when required. And let's have the be human approach. That is what will give us the long years of practice too, and a lot of peace of mind as well. I am a school principal son, and I became a spine specialist because I wanted to be different, and that was by virtue of my teacher, Dr. Dinubhai Patel. And I am now in charge of enabled spine team at Service Spine Hospital. So that's been my journey from 1989 when I passed my MS Orth. And that is what has given us the enabling technology at our institute as well. So what is animal instinct? Well, hunger and progeny. Human instinct is what? Be happy with the minimal effort. That's the human instinct. What is the surgeon instinct? Well, put the knife and have the comfort with the least of the time and get the maximum finance. That's a surgeon instinct. But what is the spine surgeon instinct? Well, put the screws and maintain either mobility or have the fusion. But when I was sitting in one of these ASSI meeting at the end of the meeting with few esteemed spine surgeons, and there was a question asked, what makes you happy? And somebody said, reading book would make me happy. Somebody said cycling and going on to the Everest would make me happy. Somebody said that playing the golf would make me happy. And I was the one who said, well, I will be happy when I put in the morning operation theater one screw in the patient's back or in the patient's spine. So that is the surgeon, spine surgeon instinct. That's what I would say. Let me start with this talk, which has got a lot of messages to give. So when 5 doctors, they went on the duck hunt, GP did not shoot because he didn't know whether it is duck or not. A pediatrician did not shoot whether he didn't know that because it's a male or female duck. And a psychiatrist did not shoot because he didn't know that it's duck or not. And a surgeon, he shoot and said, pathologist, why don't you check whether it's a duck or not? And that's the current scenario of the practice. Let us not do this in our day-to-day practice. Do whatever is optimum, do whatever is required. Let's not have the trial and error base as well. So challenges which are there in the today's practice is a change, and that is a constant in the practice of everybody and in everybody's life as well. And the time, which we all have limited time, and that is how we should really practice accordingly, need great teamwork. And we have to really incorporate technology as well. So that's what I'm going to talk about with the 3 main perspectives: management perspective, surgeon perspective, and the patient perspective. So, and when the surgeon is a management part or management is the surgeon, then the life becomes really easy. And that's really seen in the day-to-day scenario of many of our practice and hospitals as well. So management perspectives, when surgeon is an administrator, it is easy to implement quick decision, and we know what is the accuracy required operation theater needs as well. But that leads to multitasking of a surgeon as a clinician, academics and administration. One really need to balance, but most of the time you fail to do that as well. What is a surgeon? If it is mental stress increases, clinical work and academic often suffers as well, but then you can really tighter accordingly. But when the administrator are involved, then they are slower to implement. Perspective changes because they'll be looking mainly at the finances as well. And that is what has given us the growth. Finance has been taken care completely separately. Whatever we have earned, we have invested. Like, you have your own car upgraded, starting from your Maruti to really whatever you can go up to. And return is not considered. But the maintenance after this gadgets purchase has been a big challenge, and that is something which really had to be tighter when you purchase something. And we always go for the 5 years of CMC whenever we buy any gadget as well. That is a small tip to share. What are the surgeon's perspective? I have put 4 questions to all the surgeons, and they all have given me the input and how to evolve the spine practice. And that is what I'm going to talk about separately in each of the slide in the coming few minutes. So how to evolve? I think what we do at SIOR, anybody who comes with fractured neck of the femur or fractured wrist or OA knee or OA hip, we really refund the money and send the patient to the colleague who is doing that particular subspecialty work. So we develop the expert practice. That is how you can come over the challenge of spine surgery as well. Refer the other orthopedic surgeon. Then hard work and dedication towards the practice is one of the most important aspects as well, and remain available all throughout. Doing time-tested surgery first, that's been something which was one of my colleagues said that that's what anybody should start working on. So that really, and then you go according to the technology. Graded approach for the physiotherapist, and we should really have spine associated staff, and we have to continue with the patient public education as well. That's how you can evolve the spine practice. Remain available. Availability makes the most important aspect of any practice. Anybody, and I'm available from 6 a.m. to 10 p.m. and that's what I have been doing from the day I started my practice as well. And that's how we develop the practice. Most important aspect is agree to disagree. That is something which we follow. We do not consider disagree. We always have the question answer with each other, among each other, and we are usually questioning each other as well. And at the end, we agree with whatever we have disagreed on. So that is very important aspect of changing the practice. How do you continue? Yeah, I think what we should have is the own treated and operated patient. Usually they are the best, and we should have them compassion, treated with compassion as well. And that will give us the practice continuity. This is most important. We have a dedicated team to call back patients who have complication or who have a long stay in our hospital, and that is what we maintain into the silver book. This silver book word came only because it has got a silver the cover, and that is done by dedicated physiotherapists, and they give feedback. Even call the patient as well, and that is where the meticulous record keeping will come into the practice too. Interconnected, so I think surgeons have to remain interconnected. Careful incorporation, changing the priority every 5 years in the 30 years of the career. That's what anybody would have, and that has to be weighed accordingly. You really have to consider the colleagues changing priority too. Communication becomes the key if you really want to remain together. If you really want to remain together, I'm available. That is what something, and disturb me. That's the approach which I have. So anybody can call me anytime, and I never ever question them, why did you call me? And whatever busy I am, whatever day of the time or whatever day, whatever it may be midnight, I'm really available. So that is something which we have. Respect each other, understand each other's limitation and accept it. That is very important, because if you prioritize that, then we will have the winning situation as well. Unified treatment plan, academic discussion, and we certainly have celebrations now and again. We have every 6 monthly blood bank camp, and we really have all this, the celebrations going on according to the day, like Dhuleti, like Holi, like the Diwali. We have such gathering as well, annual day gathering. So such kind of gathering which we keep on doing, along with the patient education program where we have the dramas as well. How to remain together? Transparency. Each team has to be really respected. Each individual of the team share the revenues accordingly. So that is very important. So over the period, you may find, oh, I need to share, and we really should be sharing the revenues as well. Ownership value has to be considered, and somebody who is trained from your own unit will have the values of that. And hierarchy, well, I have been struggling to maintain this word hierarchy, because that is something where the caveats will come, a lot of paradox will come. How to maintain the hierarchy of somebody who is 20 years now and how do you really give them the practice accordingly. So that becomes a real challenge in the current practice as well. But then you have to really keep working on it, keep discussing, and keep evolving. And this is something where our HMS, our hospital management software, will come. Patient son called for the medical certificate, workplace litigation. So we have that green, red, yellow, and black flags to follow. And we usually have this kind of conversation on the computer box. So, anybody who opens up will have that communication which has happened in the past, and somebody who is taken care will be taken care accordingly. Improve the outcome. Well, I think we really need to be humble in accepting the mistake, be bold, declare to the patient, and invest early in the latest technology so wisely, because that is very important. And we have to really have audit now and again. That will certainly help us to progress and to improve and have the introspection in the audit. So that is again, agree to disagree will come. A lot of question and answers will be there among all the medical team too. Be prompt and correct the measures. So something that has gone wrong, be prompt, correct the measure. That is very important, and that will give us not to have this repeat mistake again. And this is something which we really, follow, because counseling is very important to improve the outcome of the patient. Patient's perspective, I think what patient needs is affordability and the care, and that is what we should be really balancing as well. So sometimes, you may have to really waive off the money, then usually we often do that as well. One-stop treatment has to be at one center with all the facility, and that should be with the proper patient education too. So ABCD of spine center: adhere, follow the protocols, be human, follow the humanity, communication, have the checklist. We have 3 checks. What we call it as the 3 checks would be that, first seen in the OPD, second one is seen by our fellow doctor, third one is a consultant's pre-operative round. Then we have the discussion. So these are the 3 checks which we follow dedicatedly all the time, and dedication to the practice is ABCD of the spine center. I would like to end with 5I. Ego. We have to use the same language. Refer the patient among our own group. So we bury I. I should never exist. So there is no ego among our group. Input. A good clinician has to give proper input. We are developing the satellite center. That's what should happen. In Ahmedabad only we are developing a satellite center. Protocols to make so that everyone speaks the same language and should be available as well. That will make the good the center too. Involvement. So decentralize the work. So we have we have somebody who is doing the oncospine, somebody who is doing the deformity, somebody who is doing the minimally invasive work, and somebody is doing the anterior surgery. So that is how we have decentralized the work as well. Investment without expecting the return. So everybody, whoever is coming from all the investment or all the income should go into the one kitty, and then we distribute. And inherent the complication. This is very important. Inherent the work that's been done. Inherent what's been at severe. So review the work periodically. So the future challenges we all know. Google Doctor is coming in the big way. And anybody who comes, and particularly millennials, Generation Z, they are the one who are the decision makers, and they practically do the Google, and then you have to really reply all that. Practice scenario has changed completely, and probably we will see that happening in coming 10 years, and it will be completely different. We will be many of us, and we'll be working accordingly. These are my car numbers, so that is how something we know. I started with Maruti. Now whatever we have, accordingly you really need to upgrade. Then why not to upgrade our own operation theater, which is giving us, we consider it as a temple, we consider it as a kitchen, whatever way you want to consider, but that is something we have to really keep upgrading. And to maintain that, you have to work for the same as well. Same thing which we do with our mobile phones, and EverP, audio, video, medical equipment, they have to really upgrade it. So there is only one Dr. Bhojraj, there are maybe 10 Dr. Abhay Nene, and there are probably, around 50 Dr. Shailesh Hadgaonkar, and probably there are, 100 Mirans, and in the coming days, maybe 500. So this is something which is a clinical scenario as well. Thank you for your patience hearing. Thank you for your attention, and thanks to all colleagues, including
Wonderful presentation, sir. Questions from the faculty?
Yes, sir. So thank you so much, sir. I think it really you provided insights. And I think this is basically the vision that you would have developed so many years back. You would have actually had it in your mind, and that is what you have put it into reality now. So, but I would like to ask you one question. If you want to do something, what you had started 20 or 30 years back, if you want to do it something like that today in a city like Bombay, so what would you advise us? And how should we go about it?
My advice is clear cut. It's a group practice you have to have. It's a subspecialty you need to develop. So 4 or 5 of you get together and develop the subspecialty and stick to each other. The first comment that you make that I would have developed the dream and dream has come true. Honest answer to this, I never ever developed any dream. I never ever, it's demand and supply I have followed. My demand was so high, and gradually, if I may share, one more important aspect, I never wanted to become doctor. That's the scenario of many of us. I was engineer student and I wanted to become engineer, but I'm doing the engineering work on the human body. So that is how I am, saving my satiety. I never wanted to buy Maruti. That's the first thing that I did. I never wanted to stay in Ahmedabad. Ahmedabad was at that time when I was a BJ medical student. It was all, lot of gases were omitted, from the chimneys of all the industry. And so I never wanted to be in Ahmedabad. I never wanted to I wanted to have the job. My father was school principal, so I always wanted to do the job, but I ended up doing the private practice. So it's a demand and supply. So my supply, I have increased accordingly. And same thing, everybody should follow. 5, maybe 7, maybe 10 of us to get together. But I would say only one thing. I think the family has to be all the time involved. Family has to be honored. I probably would say that I have not honored, but I have no regrets about it. I have been sort of, lucky enough. And that's what I would say. My anesthetic says only one sentence. You have been singularly lucky because everything has fallen in place, starting from my colleagues, from my team, from my family. Everything has just fallen in place.
Right. So, Pramod here, I think it was an excellent talk. A newbie like us, it gives a good perspective. I think you gave a blueprint also. I think what is required evolving is a group practice kind of a thing. I think for what is the biggest challenge for a newbie like us, I think 5 years, 6 years into your practice, is when do you say it is a time to go for a spine center? Like you can practice. Do you think really that right now is the time where you can really go for a spine center, or you should have a spine center with your team?
No, I think the time has come to be a individual spine center overall, because that is where you can survive. And I would say spine center, the spine center, meaning you are catering from C1 to coccyx, along with all other facilities as well, meaning, the lifestyle modification and all that, because that is very important. You should be able to cater everything in one center. And that is something which you should be doing rather than, having the multi-speciality.
Right.
The phenomenal work, and we all know.
So suppose you have a different specialty, but patient must be selecting their own doctor. Maybe maybe one of your team member is doing anterior surgeries, and he is getting more of deformities. So how this goes in your setup?
Yeah. So what normally we do, I usually identify and I usually tell that my colleague Ajay is doing endoscopy, and I will be there. If at all you want me to be there, I will be there. So that is something which I share. Suppose scoliosis case, which I do not do, and I openly tell my patient and I refer the patient before admission itself that, you go and meet Dr. Ajay. He's the one who is going to make the plan. And in order not to lose the patient, which is always an anxiety, I often say that, you be there, and then I request Ajay to talk to me. We also have frequent AK to B, means Ajay to B. So many at times when patient is seen by Ajay and says, can I not be reviewed by Bharat sir? Then they will certainly, Ajay has, that is why I said no I. So if the I is not there, then this thing will not exist. What Dr. Neeraj is asking, so that is how usually we set it, okay, B to AK or RR to B or RR to AK or something like that, has to go on. And that is what we have the system at our place.
Thank you, sir.
Thank you, sir. I think it was a wonderful presentation, and what a teamwork can do under able mentorship, which we have seen from Dr. Dave's talk and how he has developed and how they are managing challenges in spine practice. Thank you, sir, for this wonderful treat. And we will move on to the last segment of today's symposium. And we have two interesting cases. Dr. Sonavne from KEM is a professor. Sandeep, we know as a true academician, will be presenting his case. And we have Dr. Parimal Ade will be talking to all spine surgeons, neurosurgeons, and orthopedic surgeons about importance of the finances, the stocks, and he is one of the legends in this, which he has offered us today. And he'll be talking about at the age of 30, 40, 50, 60 years, how you should plan your finances in a very short presentation. So Parimal will be with us in short time. Over to you, Sandeep.
So thank you, Shailesh. I am also looking for the last talk by Dr. Parimal. And can I share my screen over here?
Yeah, yeah.
My screen visible now?
Yeah, we'll go for a rapid fire so that
right. So I'll just rush to this case because we are short of time. So this is a patient of a congenital dorsal scoliosis of a 13 years old male patient who came to us with weakness in both the lower limbs of 1 month duration. He had bladder bowel involvement also. He had deformity of the upper back, which I had noticed 5 months back. The birth history was uneventful. On examination, he had a truncal shift, shoulder asymmetry, and left chest fullness, as you can see over here. The rest of the clinical examination was normal. Pre-op neurology, the upper limbs was normal. The lower limbs, he was severely spastic. So in short, he had non-functional lower limb power with spasticity with bowel bladder involvement. These were his X-rays, which showed the presence of a D3 hemivertebra on the left side with an 80 degrees curve and a kyphosis of 70 degrees at that level. This was a 3D model, which also showed that he had a D10 hemi of 30 degrees at the lower level on the same side, the left side. And these are dynamic films which do not show any sort of correction. All the investigations were normal. The PFT was moderate restriction. He had no congenital heart disease. The ophthal reference was normal, no abnormality detected. He had cord compression just at the level of apex of the kyphosis at T3 level, and the CT showed the presence of a classical hemi with canal dysplasia. So here we have a patient who's a 13 years old male, double hemi D3 and D10, cervicodorsal kyphosis, truncal shift neurological deficit. So the management options, obviously, whether to operate or wait, which is not an option right now. One or both the levels. If D3, what is the procedure of choice? What would be the implant? What are the anchor points and single or stage procedure? So Shailesh, do you want me to proceed or we can just open up a couple of questions?
Just, yeah, you can proceed, yeah.
Right. So these are the questions in my mind, as would be in all the questions in all your mind. So the plan was deal with the neurology first, then concentrate on the sagittal balance, and the coronal balance will come in last. The approach I decided was posterior with a D3 hemi excision, correct the kyphosis, fix into the neck, and also I took suggestions from 2 other deformity surgeons in Mumbai who said that since the neck was severely dysplastic, it's better to go and fix it to the occiput to get a good hold and then sort of remove the implant later on. So issues here were single or stage procedure. I personally planned it stage because the kid was, I don't think he would have gone ahead with a surgery of long duration. Anchor points are again an issue, how to control the degree of rotation and hold the correction. So as I said, I decided to keep it stage, plaster jacket post-operatively. I got a 3D model printed, which gave me a good indication of 1, the deformity, 2, the anchor points which I wanted, and exact amount of resection that I would need in this particular case. Again, as you can see over here, the 3D printing gives a good, accurate detail of the anatomical landmarks. Also, there were severely dysplastic pedicles proximal to the D3 hemivertebra, which probably could not have been, I couldn't have been put in pedicle screws over there. And this was the plan which was made. On the left and the right side have 3 anchor points superiorly, 3 anchor points inferiorly on both the sides, depending on the study that we did on the 3D printing model. So intraoperatively, these were the things that I did to correct the deformity. Once I did, removed the hemi on D3, it was very difficult to control the translation of the column, as we all must be aware. So what I did was that there was a combination of these things like compression and distraction on concave and convex side, rod rotation to actually get the correction. And the most important thing was the head lifting. So I usually put this patient on a head frame, horseshoe, and somebody while correcting it, I use reduction screws proximally and lift up the head to correct the kyphosis. So this is what was done. And this is the post-operative X-ray that I got. I got a fair bit. I tried to keep it under-corrected because there was a hemi on the lower side also. I got a good correction, used a mesh cage posteriorly, grafted it quite well, got a good correction of kyphosis over here. And this is the clinical examination in the post-op second day. So Shailesh, I would stop over here. And this is actual video that I have taken of the patient. So can you make out anything over here?
I think she has not been able to.
Yeah, so that's the
vision issues.
Yeah, visual issues. Yeah.
Right. So this patient had vision issues on the right side, which disturbed me quite severely. And then we went in. I thought whether there was a vascular injury. We got an MR angio done, which was showing normal vasculature. There was some amount of orbital cellulitis with edema. So we started the patient on steroids. And we got an ophthal reference done, which showed that they probably thought of, they were also confused. They could not diagnose whether it's an oculomotor or optic nerve injury initially. They thought of an anterior chamber drainage. And this is the USG, which showed a right central retinal artery thrombosis, which was confirmed on the OCT. So this was a case of where the patient had an immediate loss of vision. So any ideas on this, Shailesh, Neeraj, Dr. Dave Saab, any experience about these cases that you all have?
I think, means this is again a very, very challenging scenario. I have personally no experience of such patients so far, but wherever we have seen, one is that positioning, one is that how you give that importance to the iPad and the blood pressure. And these are the very unfortunate, scenarios where we really despite of taking all the precautions, this can happen. And I think there is no clear-cut answer how we can prevent this. Important
so Neeraj, Samir, if he's around, Dave Saab, anybody who can, why has it happened? Is it only related to positioning or hypotension, or what could be the real cause behind this?
Sir, hypotension might be the cause, but I think most of the time it's positioning issue. Especially we might not have the ideal kind of setup or tables in most of our scenario in public hospitals. So the anesthetist typically give one side lateral positions, and we sometimes may not get a proper prone position with the eyes are free. That kind of attachments. So I think these all things make the risk of visual loss high. So in my setup for such cases, I do some jugaad. Along with dish traction, I put some boxes supporting the thromovac drain packed with some clothes, the drapes, and we make it a solid structure and we support this head.
Right. So Neeraj, I would just like to interrupt over here. In all my cases of deformities, there are 3 people who check the eyes. One is the anesthetist, second is one of my colleague who's washing up with me, and third is I personally sit down and look at the eyes. In this case also, I had done the same thing. Before starting the case, I make sure that the eyes totally, I put in my fingers because I'm really paranoid about this.
What was the position given, sir, for the head?
So this was a horseshoe. It was on a horseshoe. So I'll tell why it has happened. So when we were correcting the deformity, when somebody lifted the head, the kyphosis got corrected and the patient's neck got anteriorly translated. Also, we had to rotate a bit while putting in the rod and rotating it. So while rotating and lifting the head, nobody could actually see the eyes, right? So the patient's head shifted on the horseshoe, wherein the right eye, the left eye went inside the gap and the right eye landed directly on the headrest. So that is how it happened.
I want to interrupt here. Yeah. Actually, horseshoe is a known risk factor for this complication.
Right.
Using horseshoe and other is Wilson frame. These two are known for having this complication.
Agree. So I'll just go ahead. and tell you the literature. So this is but this patient started recovering 3 weeks post-op. He had good functional, he had almost grade 2 power, but his right vision loss persisted. So then we went through the literature, and as he said, there's quite a lot of literature on perioperative visual loss. And this is something I want to highlight for the younger guys who are watching this particular symposium, how to take care of these things. Because deformity correction is something which is on the mind of the operating surgeon all the time, but these things are very important. And these are some of the literature. So the incidence of perioperative vision loss is from 0.094% to 0.2%. It is more in prone spine surgeries, but also reported in lateral surgeries and hip surgeries. That means pressure is not the only reason why these patients can have perioperative vision loss. As suggested, ischemic optic neuropathy is because of hypotension. There are other risk factors which are associated like smoking, diabetes, obesity, anemia, preoperative post-intraop hypotension, Wilson frame, head low position, which increases the intra-abdominal pressure and causes more pressure into the in the CSF. But the point here is that this patient did not have an ischemic optic neuropathy. This patient had what is called a central retinal artery thrombosis, which has got a less incidence. And this is something which is caused by direct pressure on the eye. And it is also called as acute stroke of the eye. Classical symptoms are painless loss of vision, immediately diagnosed post-operative period. There is evidence of trauma, which could be because of pressure like corneal abrasion, ptosis, unilateral erythema. And basically it is because of emboli, direct pressure to the globe and increased intraocular pressure. And as Dr. Abhishek said, this is also because of the the headrest can be one of the reasons for this thing. So the point for me to present this case over here was small things which we could miss intraoperatively, especially during the stress of a major surgery, carry a bigger impact on the patient's life. And I'll show you why. This is the patient's video. He's walking comfortably right now. He's totally recovered from neurology. He's doing all his activities, going back to work. Unfortunately, this patient has lost vision in his eye. So the deformity was something which was on our mind, but he's gone back with vision loss, which probably could have a adverse impact. So this is a point I wanted to make. Over to you, Shailesh.
Yeah, very, very nicely summarized, Sandeep. And it was a very challenging case, though. It was very well planned and executed. And the role of 3D bone models in such bad deformities is really a very, very useful thing. That's what one learning. And second is we have to we have to keep everything ready for any problem, because these things never come in a package. These are surprises which always teach us what we should do next. And there is always a learning. Excellent.
So as Shailesh, as Dr. Davesa said, that it's important to have a team for these particular cases, because it's not only the operating surgeon is always thinking of the spine issue and how to correct the deformity.
Absolutely.
It's somebody else who can take care of all these things and help us out.
Absolutely.
So thank you very much. And I think, Shailesh, you can move on with your last case before we move on to the last session.
Actually, can I add just a thing on vision?
Yes, please.
Yes.
So, I mean, we had an interesting case in which there was post-op vision loss, but the child had IOL and high myopia already. So while extubation, they gave atropine because there was a drop in the heart rate. So the eyes got dilated so much that he could not see. So then once the reversal of atropine happened, over a period of time, they gave some drugs for that. Then the vision came back. So that is also one of the causes of vision loss, which I don't think is documented well.
So Abhishek, that's a good point. And I think in all these deformity cases, we explain about everything, neurological deficits, might not recover. We never, I personally never used to actually go out and explain about vision loss, which is a significant intraoperative complication or event, you can say, but which is not a very underreported event in deformity cases.
So we as a team always inform about visual loss, but now to make it more palatable, because no one tells about that, we say that they can be visual disturbances. We use high quality padding, but despite that, this is a very rare event, but it can happen. But we have been consenting for it like for past 8 years with this. Love.
Same here. We also consent because we really don't know. Next case can be trouble.
I think about vision loss, it is very much less spoken about, but it is very much necessary to mention it on the consent, and we also have been mentioning it.
Right.
Yeah.
Just to add, in our practice, I have just mentioned about the boxes. Another thing, what we do, we just keep the head hanging over the traction. So everything is free. Just a halter traction during deformity correction, and the head is just hanging. So,
Dheeraj, that is something that I have also seen the neurosurgeons do quite a lot, But the problem in this case is that if you do that, suddenly you do a lot of release and the whole column translates anteriorly. It's very difficult to have control of that anterior column unless you have good anchors in the proximal segment. So that's why you need this sort of headrest to actually support it temporarily.
Okay. But we have never found sudden opening of wedges, but we'll take this next time. We'll be aware of this. Yeah.
Right. So I think we can move on to Shailesh. You can present your last case before we move on to the...
Yeah, we will go for a quick rapid fire because we are really short of time. I will not take much time. Is my screen is visible?
Yes.
Yeah, so this is a case of angstpond, and this was a 54-year-old gentleman. He had a fall, and he was a known case of angstpond. And when he was presented to us, he had a lower limb weakness, and this is what was his X-ray. We can see a cervicothoracic region.
Fracture dislocation.
Yeah, fracture dislocation. And this is how he was presented to the casualty. And a lot of learnings, there was nothing given to him because a lot of people were not understanding whether he had anything, and he had weakness with all significant instability and weakness in lower limbs, and assessment was quite difficult because of his angstpond all throughout. And this is what was the CT scan, where we can see a lower cervical fracture with translation and overriding of the posterior column. And it was a very tough scenario in this sequence because we are seeing significant pinching of the cord at that level with the posterior elements. And this is what was the picture. And I'm sure that we have faced these situations.
What was his deficit? He was total or incomplete?
He was incomplete.
So what's your question, Shailesh?
No, there is no question because it's always that we feel that we can do this posteriorly. But at times it can be challenging because he was incomplete. Giving position, we have seen people talking about, I gave the position, we fixed it, we reduced it, and patient became total. And that was always a nightmare because, this is a chalk stick fracture, what carrot stick injury. The head and neck is one segment and the torso is another segment. It's difficult to contour. We have a large share of difficult and complex thoracolumbar, cervicothoracic fractures, and we are doing one of the large numbers in the country. But such situations are really challenging. And sometimes we feel that just giving them supine position in the same thing what they are and doing anterior job first probably is a safe approach, and then thinking about the posterior. Or you can do stage both the things on the same day or a week later. And this is what was the fracture. Again, as we all know, this was the challenge. And we plan for anterior surgery. And we do a lot. We have our experience of spondyloptosis, where we have done some reductions at a monoblock with a single level. And in such situations, this is for learning for the junior colleagues and fellows that the positioning is very, very important in such patients. We have to keep an eye constantly. Even intubation, fiber optic intubation is required in such patients because it can be very, very difficult and challenging if you're not doing that. We have a complete team of people doing this, and this is what the position is. And though it looks so easy or simple in the X-ray or in the CT, it's not that easy because after the exposure, there was no movement at all. The segment of neck and head was complete one. It was not moving with traction. We had given Gardner Wells and all these things, but it was not. It was like a rock. and head was not moving. There was no traction was helping, and we were stuck. We thought, what should we do, and whether we should turn the patient posterior and try something, because again, thinking about posterior reduction would have been a nightmare. And then we thought of the maneuver of reduction over the cage. And we were lucky that we distracted. We somehow managed to distract, and we fixed this up to D1. And this was on table fixation, and we were very happy. If you see that posterior elements which were compressing the cord went back reasonably, and we were very happy to see it in O-arm that this looks really good. I tried, but it was really complex because the angle was very steep. Going to D1 also, that screw was very, very challenging. I thought of putting 2 levels below, but it was practically impossible. And I thought, okay, fine. We will, anyway, we got a very good reduction. We got a very good interbody cage. We will plan for a posterior fixation. And initially, I thought we'll do it stage. And this was the O-arm picture on table. I thought this really is very strong. And something like a spontaneous fusion in Aiyer we see. I was very hopeful for that. And I thought of doing the posterior at a second stage in a week's time.
What was the neuromonitoring? All fine?
No, neuromonitoring was not used because he was incomplete. And this picture, we were very happy. If you see that it was distracted completely, the screws and the plate looked very, very good. We explained the patient, and for various reasons, patient was very happy. And in second, third day, he started moving his lower limb better than what it was when he was brought up. And this is the, and we were very happy. We thought, yeah, we'll just do the posterior job after a week. And after 3-4 days, the CSF started coming out. And because we had kept the drain for 2 days, there was nothing. And then the CSF started coming out. We were really puzzled what we should do in this situation. We took opinions. We asked the anesthetic. They told that, no, it is practically difficult. We thought of lumbar drain, and they told us it's not possible. It was draining almost 400 to 500 per day ml. And after 2-3 days, we thought we only will take a call. And we did a CT scan of the lumbar spine, where we initially thought, a lot of people gave us that you can do a posterior surgery lumbar, do a small mini open, make a bore and put the drain at the lumbar spine. But we did a CT where we could find this gap on the CT, and we thought we only will do it. And our team was there. Siddharth was there. We did this, the subarachnoid drain. And luckily, it started working. And 3-4 days, the wound started healing. There was no CSF. And we were very happy. We told this patient, now we will do the posterior surgery. For whatever reasons, he was getting better. And the family and the patient decided that we will go home. Now we are exhausted with finances or various things, as we all know. Everything is not in our hand. And the patient decided that this is the lumbar drain. We kept it for 5 days, and we were lucky that it completely worked out. And the patient went home, and for whatever reasons, didn't come back as told. And he came at 2.5 months post-op. And this is what the X-ray looked like. Fortunately, that distraction and the magic of that interbody, which was really holding it well. And this is the X-ray. I missed a bit when I saw this X-ray, but patient was improving. His power and everything was improving. When we saw this, we did the CT scan, and we did a CT, we did a MR, and we told that you will need definitely surgery. And we need to fix you from the back. Because when we saw the CT, this was holding very, very well. The cage was holding well, though the lower screws were coming out, but this interbody cage was one sigh of relief. And we told that you get admitted. Patient did not get admitted. He was very happy. And he said, no, we don't want to get admitted. I said, oh, boss, this is not good. You should. And then somehow he planned, he came back again. This is the CT. I was quite happy for the interbody which was holding, but I thought if it displaces, then it will be a nightmare. He came back after 3 to 4 weeks of that, and we did a posterior surgery. And again, we planned for above and below. It was a tough, challenging one to again put him into the similar situation. Luckily, the OARM we use nowadays for most of these cases, we could put the screws in above and below levels, and you can put practically pedicle in. We are putting in all practical levels in cervical and every spine nowadays. That's the big advantage in such cases where you can really get a super strong hold, and you see narrow pedicle, thinned out pedicle, dysplastic pedicles. We really can get our screws in. And this is the posterior fixation, which we manage. Again, it was challenging to put screws at above and below levels. I will not go in view of time, but the angles, and we were lucky to get this. We studied the anatomy anteriorly. There was nothing which was coming in the way of the cervical lower end, the lower plate, and we thought of just keeping it as it is without doing anything, because it was not compressing anything. Luckily, if we realized that the cage, which was like like a God gift, was sitting very strongly out there, and this is his picture, and he is so far doing fine. He is significantly improved in terms of his power now, which was weak, and this man is significantly happy. Now it is just around 1 month post-op, and I had kept him in just bed because I didn't want to take any chances of anything, but we will be mobilizing him soon. And various things are there in literature, but I think each case is a unique case which teaches us, how we should plan and how we should do things in such scenarios. Thank you everyone for patient hearing. Thank you.
Thank you, Shailesh. Superb.
Any critical comments?
Yeah. Shailesh sir, one question. So when you did the anterior surgery and distracted, was there no CSF leak at that time during the surgery?
Hello?
No, there wasn't any leak.
Yes.
Okay. Yeah.
Sorry, there was some lag. Any comments, please?
Okay. So any reason you found out why there was a leak in CSF after 2 or 3 days when it was not there intraoperatively?
No. Yeah, that is a very important question. Initially, when we exposed, there was very small amount of leak was seen, but nothing came out, actually speaking. And we put, because this was a bad injury, we had kept in mind that there is going to be a CSF, but luckily didn't come anything. And when we put the cage, it completely was absolutely normal picture. There was no leak or anything. Initially, we thought maybe something, but some fracture, but it was not a classical CSF leak which was seen. When it was, and the drain was kept. Maybe some distraction, something is opened up and it started pouring.
Right.
Any other comments? Critical comments?
I think you have done a good job. Excellent presentation.
Thank you, everyone. And we would like to proceed with the most important presentation of today. And that's again a non-academic presentation by none other than Mr. Parimal Ade. Parimal is a finance consultant, and he is holding very big portfolios in the country, and he has his own company called as Invest Yagnya for last 15 years. He has a very big team, and his YouTube channel is more than 5 lakh followers for him. And So, and he's a very thoughtful guy and a dear friend of mine. I would like Parimal to come on stage and share what we should do at the age of 30, at the age of 40, at the age of 50, at the age of 60. And we really don't know, as everyone says, doctors really know, just understands going to the hospital, seeing patient, doing surgeries, but we are very poor in finance and management. Over to you, Parimal.
Yeah, thank you, Shailesh sir. So it is a pleasure. So I was listening to a few doctors. I didn't understand anything, but one thing is sure that I chose the right field, that coming into finance rather than medical. There is no doubt. So respect to all you people, the kind of work you people are doing specifically during the pandemic and all those things. Definitely, I think hats off to you people. I think, so how should we do? So should I share the presentation or should we have a discussion majorly?
You can have a presentation and then we can discuss.
So majorly I'm going to discuss on financial planning process and some investment part. And then let's keep it open so that you must be having a lot of practical questions about investments or financial planning or markets. What exactly is happening, recession, no recession, or what things. So I think I'm just sharing a presentation with you. So just give me a second.
Parimal, just one request, try to make it as simple as possible.
Yeah. So I'll keep it very simple. No problem. So is it visible?
Yes, can.
Yes, just a
second.
Maximize
the screen.
Yes, that's all. So yes, I think financial planning, the process I'm going to discuss today, what should be the process. So I think a lot of times what we do nowadays, a lot of people approach us with investment products, specifically as you people are quite busy people. So majorly your bankers, your relationship managers or wealth managers or some relatives or neighbors or patients come up with the products to present to you. So I feel that that's the worst approach one can have when you are investing. So the approach should be a financial planning approach and not specifically what we can say as a product approach. Normally, if we look at the product approach, then the problem starts. So when we are looking at the products, the returns is the only portion which will drive our decisions. So that's the problem. So in the financial planning, the suggestion would be we should go with a budgeting thing, like knowing our current situation. What are our inflows? What are our outflows? What is the surplus we are having? And the most important part is what are our financial goals, whether they are short term or long term. So normally, if the financial goal, you want to achieve some kind of financial goal and the horizon is less than 3 years, so it can be considered as a short term financial goal. And if it is 3 to 5 years, it is a medium term financial goal. If it is 5+ years, it's a long term financial goal. Why I'm suggesting these short term, long term, medium term? So I'll explain which kind of investment options one can choose. But to start this journey, we should know that what exactly we want to achieve. So achieving, if we know what we want to achieve, then the product selection, the investment option selection will be quite easier. Now, once we finalize this thing, okay, this is the goal we want to achieve, then strategies to achieve your goals. In the strategies, majorly, every person is different. Some people like fixed income securities. Some people are exposed towards more real estate or gold. Or I am seeing a lot of investors, new investors are coming into the market. They are quite interested about investing into stocks or mutual funds or equity markets, specifically because the recent rallies which have happened between after 2020. So I think a lot of exposure started in that way. So that's why. So developing strategies means finding out your risk profiles, and according to your risk profiles, you should start investing into those things. So once you identify your risk profile, then you can go and start looking for investment options. So in that, which option should be there? So that is the next slide I'm going to discuss with that. And once you select those options, so monitoring at least once in a year, you should have a detailed discussion about your financial planning, and you should include your spouse also in these discussions. That's very important. So knowing whatever investments we are having, noting down or writing a will or something like that. So those things are part of this financial planning process. So now this is the rule normally I suggest people to follow. That is 50-30-20 rule. So, and I think majorly this rule should be more applicable toward when you are in your 30s or your 40s. Once you cross your 40s, I think the saving part can be on a higher side. So 50, what does this 50 suggest to us? So 50 is maximum expenses we can have. So if you are earning 100 rupees, the expense part should be 50%. In this 50%, your household expenses and your EMIs should also be included. So that's what. So this, a lot of people ask you, what is the maximum home loan I can get? Or normally you are in practice and all those things. So business and all those things will also be there. So typically we go overboard with these kind of borrowings, whether for business borrowing or for home loan borrowing or some other loans you are taking. So my suggestion would be restrict your expenses, including your EMIs, to 50% of your income. At least 30% of your from your income should be saved for your long-term goals, like your retirement. This is the goal I think a lot of people do not plan at all. So long-term goal, the first priority should go towards your retirement goal, and then your kids' education, higher education, and marriage, and all those things one can include. And remaining 20% can go towards your short-term goals. Short-term goals like buying a vehicle or going for vacations or something like that, or having some medical emergencies. You are in this field, so I'll not stress more on that. But this 20% could be a floating kind of thing, which can, some people divert this 20% towards the 50% and they go for more home loans or other type of loans they go. But at least 30% of savings is very important. That's what I genuinely feel in this case. Now we will go towards the next discussion. This is, I think, is going to be an important thing. What kind of investment options one can choose? So this is a kind of thumb rule which we have made. So it totally depends on your investment horizon. If your investment horizon is less than 3 years, so this is how one should look at. So this left to right is from the risk profile from low to high. If you are quite low risk profile or very conservative kind of risk profile you are, so then investing into fixed deposit or recurring deposits or debt mutual funds or conservative hybrid funds means majority of the investments goes into fixed income securities. Hardly 20-30% goes into equity, that is stock market they invest into. If your investment horizon is 3 to 7 years, then you can have a hybrid kind of approach. Again, the risk profile graph is like this from low to high. The product selection should be like this. So 3 to 7 years, low risk profile person should invest into conservative hybrid funds or equity savings funds, majorly 50-50, 50% equity, 50% debt. Aggressive hybrid funds are like 65% equity, 35% debt. Index funds you must have heard about a lot, like Nifty 50 or Sensex. Nowadays we are hearing a lot. And large cap funds means majorly they invest into blue chip stocks. Now, when the investment horizon is more than 7 years, so then the investment options can be little aggressive. Like you can invest pure equity stocks or blue chip stocks or large cap stocks. If a little higher risk profile, multi-cap means small, mid, large cap means typically first 100 companies of India are blue chip large cap companies. Next 150 companies according to their market capitalization means total valuation of that company are mid cap companies, and rest all companies listed in India are small cap companies. So accordingly with your risk profile, you can start taking allocations towards these small mid cap, small cap, or even investing into direct stocks also if you have that much of time with you for investments. So this was a limited presentation I had. I'll open this dais for more questions and answers. So I think that will add more value to us. That's what I feel. Yes, Shailesh sir.
Very well. It was an excellent presentation and a very short time for practicing doctors. But what I'm seeing, there's an increasing tendency in younger generation in our city or everywhere that they are starting it very early. Their interest is quite a lot in stocks. Is it the right age? What is the right age for investment?
I think definitely the right age is like Warren Buffett started at 11 years old when he was 11 years old. So there is nothing right or wrong, but I strongly feel once you start earning, So I think you should start planning your investments. That's the best part. Nowadays, hearing from somebody, some tip is coming and investing into stocks, I think that is a wrong approach, I strongly feel. So it's always better to start with those businesses which you can understand. And if you do not have time for analyzing these companies or businesses or investment options, it's always better to go with index funds. So what are index funds like Sensex and Nifty? Every day we hear about that. So investing in those companies or investing in those index funds also will make a lot of sense. See, our economy is going to grow at 7-8%. There will be an inflation of 4 to 6% in our economy. If we add these two numbers, that is the nominal GDP growth. So if we are a layman also, so our equity market will grow at that nominal GDP growth rate. So adding this GDP and inflation number is what one can expect from equity from the long-term point of view. Obviously, this is a listed asset. So every day buying, selling is happening, and that's why we are seeing the volatility. But ultimately, if we look at the trend, whatever earnings growth we are going to have from these companies, that is the bare minimum expectation one can have from equity market. It will not be a straight line. The path will be volatile. The trend will be positive. I think if we look at the trend, that's what is more important when we are investing into equity market.
Okay, I will ask you a real-time question. Like a doctor who is trained and now he's practicing, is doing reasonably good. At the age of 35 to 55 to 60, he's seeing patients, he's busy, and he always feels, no, I'm not doing stock market or something. And some anesthetist or some colleague is doing some trading. So what is this trading and what is investing? Someone who is reasonably busy, what they should do?
Yeah, I think it's always better to focus on our core competence, your core competence, and earn from that rather than trading. See, trading is a zero-sum game. I think it feels quite lucrative to invest into stock market, buy, sell, intraday trading, futures and options and everything. But it's why I always say that it's a zero-sum game. So somebody has to lose for somebody to win. So that's the trading business. And 99% of the retail traders lose money. I have a friend who is a big time trader in Mumbai, and he has employed at least 150 traders. They do algo trading, and he is managing almost 1,500 crore rupees of prop book. And he has so many charts and all those things. The strategies are going on. So believe me, as a retail trader, we are sitting here and doing nothing, no strategies developed. Just on some intuition, we are doing that trading. So ultimately, the small traders or investors are going to lose to these big sharks. So they should never indulge in these practices. The only practice which they should do is financial planning process, understanding inflows, outflows, whatever surplus those people are having, converting that saving or surplus into investing. That's what make you a successful investor. A lot of time what we feel, that's 10%, 15%, 20% returns if we get from some kind of investment, stock or something like that, we feel it is a good thing. No, a successful investor is that investor who achieves his or her financial goals. So I think financial planning approach is the best approach. Optimizing your savings, converting your savings into investing. I think getting 4-5% more on compared to our fixed deposits or real estate or gold, I think that's what the objective of doctor should be.
Yeah, I understand. And you think that if you are busy, maybe invest in simple good stocks like large caps and play safe?
Definitely. I think that's why I suggested. So normally when we invest into stocks, so that real-time movement can make us uncomfortable. That's what. If you can handle that thing, so there is no problem. If we cannot handle that thing, then it's better to go with mutual funds or index funds. I think that would be a right choice. I also manage a lot of doctors, so I think I understand this busy schedule is very difficult. It's very difficult for you people to find out stocks, analyze stocks, or so it's a complete process. It's like you're giving 1% and hiring a fund manager who has done MBA from IIM, CFA, CA, and all those things, and they are managing. So it's like you are recruiting them at 1% cost.
So it's a good idea to get someone who is good at it, and
definitely. I think that would be a better thing. So in investing, the free time in your core competence will earn more returns compared to stock market. I'm just saying compared to stock market. Nothing.
All the friends
no
who are
offense.
watching, a lot of viewers are watching from all over the country and abroad. I just want to know, because they are all very voracious readers, is there any book which they can read and earn good in stock market?
I think for earning or investment is all about behavior management rather than actually analysis. So I'll suggest one book from Morgan Housel, Psychology of Money. I think if you read that particular book, I think that's a Bible for investment management. So it will tell you how to behave in markets. So I think that is more than enough for investors to.
And any other movie, because everyone has seen this Scam 92, but any other movie which you will recommend for viewers?
Yeah, I think, movies are flamboyant, and that's why they set wrong examples. So for entertainment, there are a lot of movies, but for entertainment, but not for nothing to take from those movies. As an investor, I feel.
Yeah,
I have a question.
My colleagues.
So see, I think stock markets, you have euphoria and then you burn your fingers and then you feel very bad about it. And I spoke to some very, very senior sort of almost CEOs of funds. What they said that hardly anybody is ever able to beat the Nifty, right? There is nobody who has beaten the Nifty in the long run over 5 years, 10 years, 15 years, 20 years. The message being invest in the Nifty. My question to you is very specific. Between a Nifty mutual fund and a Nifty exchange traded fund, which is better and why?
See, it totally depends on the index, the expense ratio of that. So if you are investing into an index fund, if the expense ratio is 0.35%, and if you are investing into an ETF, expense ratio is 0.05% or 0.10%. So obviously that ETF will have that extra advantage. But nowadays, exchange traded fund is completely dependent on the market demand supply equation. So some tracking error could be more on ETF side, but nowadays you must be knowing that employee provident fund money is going into ETFs, and that's how the volumes are increasing. So definitely over the longer horizon, ETFs will give you that extra return if the expense ratio is on a lower side.
So could there be a scenario where the market crashes, you have ETFs, but you cannot sell because nobody is buying?
See, I think it is possible. We can see
as opposed to a mutual fund, where mutual fund they have to give you your money back, or they also may not give you your money back.
No, I think mutual fund there will not be any problem. But with ETFs, mutual funds are not liable to participate. No, so it's a demand supply equation in the market. So definitely in ETF case, if liquidity will not be there, then pricing will go haywire. There is no doubt about that.
Right. So safer. For a no-brainer, safer is a Nifty mutual fund.
Index fund would be a better thing.
Yeah, Parimal is a regular feature on various TV channels, and he keeps giving advice. And I can see that he has kept Vivekanand on one side and Warren Buffett on the other side. The more you learn, the more you earn. I think a lot from you. Yeah.
Shailesh, yeah. I'm just thinking that where is Charlie Munger? Is he behind his head giving all the thoughts?
I think I think Charlie Munger is also a great personality, no doubt. So, but I'm more tilted towards Warren Buffett.
Buffettology.
Parimal, one short. Yeah. Suppose I have a decent amount in my saving, and I also have a home loan to pay. Okay. And there is another scenario. I want to buy a property also. So I'm not sure what has to be done. Should I show that property we brought after 6 months, a year, or 3 months, whatever opportunity comes? So during this short time, how should I utilize this saving amount? Yeah.
See, so in this case, I'll say that again, the process should be a financial planning process. I understand the question is very clear, but I'll say the approach should be a financial planning approach. So example, like I'll ask you a first question. Are you investing in that another property, or are you going to use that property?
I'm going to use that.
So then the money should be parked into liquid funds, nothing, nowhere else. because stock market and all those things, that volatility should not be there. We should have a certainty that, okay, after 6 months, I'm going to need that money. The objective is not to get higher returns. The objective is capital protection and whatever extra I can get on a savings account interest. I think that's what the bare minimum expectation one can have. Liquid funds would be a good choice for you in that case.
So another, I was just checking liquid funds. So SBI and HDFC liquid, no, they have hardly grown more than 3%, and some are also negative.
Right.
So why should I invest in such funds if I'm getting such a low?
Yeah, I think in the short duration, what happened, I'll tell you. See, recent past 3 to 6 months, the interest rates have gone up. So when interest rates go up, these funds always give you very bad returns in the short duration, because when interest rates go up, NAVs go down. That's an inverse relationship between interest rates and the value of bonds. So in these cases, it's chasing returns. That's why I say I'll suggest find a good bank which is offering you 5%, 4.5%, 5% in savings account. I think that would be a better choice to invest in these markets, because currently we are seeing high inflation. So interest rates are going to go up in the short duration. So that pain could be there for some time. Though in liquid funds, I think you must be talking about low duration funds or something like that. Pure liquid funds are like maturities of 30 days. So that much of difference is not there. So their returns would be around 3.5% in current scenario.
Thank you.
Yes.
Yeah. Any other questions from our team? Okay. So I have a Marwadi friend who advises me not to go behind share market, and many person advise here it's not in our expertise. Why should we enter in unknown territory and risk our hard-earned money? So he advises, what he also does that he takes a particular saving amount and he put that into gold. He buy a amount of gold, and every time he increases the pile of gold in his stock. So what he believes that gold is always on some rise. That is one thing. And also it is anytime it is like a liquid thing. Anytime we can just go to the shop and utilize for any emergency.
Right.
So these three are the advantages. What will you suggest, sir?
See, I think the choices are not crazy. Everybody is different. So your experiences in early adult life, what makes you these kind of investors? So I strongly feel that whenever we are investing into some one asset class, or a lot of people invest into fixed deposits, fixed income securities or something like that. So there would be some experiences which they must have had. But I always feel we should look at these things quite logically. So as I explained you, why we can expect around 12% returns from equity asset class. So there is a simple relationship of GDP growth and your inflation. So that's what. So that is the kind of growth, that is the nominal GDP growth of our economy. So in our economy, all sectors are included, including agricultural, which is the worst performing sector from growth point of view. Though it recruits or give employment or give earnings to 70% of India, but still the growth rates are 2-3%, 4%, something like that. It means even after adjusting for farm sector, agricultural sector, if we are still growing at 7-8%, it means there are some sectors which are growing very well. And that's what is equity all about. So when we look at Sensex or Nifty, look at the participation in that. So it's hardly there is any company from agricultural sector. So there are other sectors, and look at their earnings growth. If you look at 15, 20, 25 years of earnings growth, if the earnings growth is between 12 to 15%, so I think that is the rate of return one can expect from this asset class. Problem happens, we look at the volatility as a risk. Volatility will work for you as an advantage when you will keep on participating on a regular basis. And that's why converting your savings into investments, that's the most important thing one can do. So that financial planning process is solution to everything you are having. Once we have that process, I think we will not look at products. We will look this as investment options to achieve our financial goals. So then selecting that will be quite easy.
Thank you. Thank you.
So just as a continuation to that, I mean, investing in physical gold, we can also invest in the stock market. Is there any way? That is what I heard from one of my friends. Like, well, you can buy some kind of commodities or.
Parimal, if you correct me if I'm wrong, I think sovereign gold bond is the best way to invest.
Yes, yes. If at all you want to invest into gold, then SGBs, sovereign gold bonds, are the best options. First, there is no capital gains tax if you hold that investment till maturity. First advantage. Then you are going to get 2.5% interest also on that investment. It will be taxable though. The problem in SGBs is that there is no liquidity available that much. So if you go into the market to sell those SGBs, the buyers are not that high. And that's why price discovery is not very efficient in that. Means if suppose in market, the rate is going on around 51,000, 52,000, you will have to sell at 46, 47 or 48,000 rupees in SGBs. That's the problem because there is no liquidity. Once the participation will increase, volumes will increase, demand supply thing. So I think price discovery will be quite efficient.
Also, the locking period is quite long here.
Yeah, so that's what. So that's why government is also offering you. Government is saving on forex because they are not actually importing any gold. They are just giving you a guarantee that we will pay you. Don't worry, but don't invest into physical gold. That's what the government is suggesting.
I'm getting a lot of queries, but I think this session is one of the most hit session, and a lot of youngsters are keen to get connected with all this. So please feel free to contact Mr. Parimal Ade at Invest Yagya. He's got a very good team and they can help our simple things. But anyway, this is not a marketing session because he's a very big man and he has given us time for awareness of all budding and aging spine surgeons. Thank you, Parimal, for this wonderful show.
My pleasure. My pleasure. It was great to interact with you people. Thank you.
Thank you. Thank you.
Thank you. Thank you.
Any other comments? Yeah. Neeraj, should we conclude?
Yes, we can conclude. And also I request Parimal to just tell about his company in brief and how we can approach and start investing with you.
See, we are majorly into equity research thing. And I have a wealth management division also. Actually, I started with wealth management and then out of enthusiasm, we started this Yadnya Investment Academy, Invest Yadnya. So there we do a lot of equity research also, and we advise people on wealth management. So majorly, we take care of the big portfolios which our investors have. So completely risk profiling, financial planning, will writing, estate planning, all. It's a family office concept. So like, it's a hiring you a personal CFO kind of thing. So it's a complete end-to-end process we manage. So investedna.in is our website. One can, if one want to explore, they can visit.
Thank you. Thank you very much, everyone.
Okay. Thank you.
Yeah.
Thank you.
So we can consider this as a conclusion of this session. Thank you. Unmute yourself. Shailesh, unmute.
Thank you, Parimal, for this wonderful session. And I would like to thank all the wonderful faculty for giving their time in this first day of this Pune Spine Weekend. Senior faculties, all of them, Dr. Dalvi, Dr. Dave, Dr. Sonavne, Dr. Sandeep, Dr. Samir Ruparel, Dr. Somanan, everyone who has contributed, Dr. Abhishek Srivastav, Dr. Mihir Bapat, and all, Kiran Lingutla. Names a few, but my colleagues, Dr. Pramod Bhilare has done a great job and constantly he was there with us for last 3 to 4 months. My colleague, Dr. Ajay Kothari, Dr. Siddharth Aiyer, been instrumental in this course. I would like to conclude this with thanking you all delegates and our colleagues to give us a great response for this first day, and we look forward for a great show tomorrow as well. Thank you once again. And thank you, OrthoTV team, for giving us a great support. Dr. Ashok, Shyam and Neeraj, Bijlani. And without whom it's not possible to conduct this show at this level. Thank you all very much.
Great show, very good program, and I had a fantastic time. Lot of learning and lot of entertainment. Superb.
Thank you, sir. Thank you, sir.
OrthoTV can stop recording?
Yes. OrthoTV Studios, Ashok.
Okay.
I think we will just leave the meeting. I will just call up Ashok.
For tomorrow, just let me know.
Yeah. Okay. We want you to be there, Neeraj. Yeah. Thank you. Yes, I will. I will send it to all the faculties for tomorrow as well. I mean, today's faculty for tomorrow's show as well.
I don't have tomorrow's program as well.
Perfect. Perfect. We'll be happy to see you, sir, tomorrow. Thank you.
Thank you, sir.
Thank you. Thank you. Thank you.
Neeraj?
Neeraj just left.
Okay.
Okay. Bye. Bye.